state-of-the-art related to orthopedic infections. And then with the intention of improving the musculoskeletal care for our patients, in particular by preventing the infection from happening. You may ask, why would you bother having consensus meeting at the moment? The reason is because, first of all, the literature is not definitive on many issues, as we all know. And much of the things we do today is really based on thin science, if any science at all. And then there is challenges for creating evidence in the field of musculoskeletal infection. To do studies, we require very large sample sizes, which makes them logistically prohibitive, and obviously it would take a very, very long time. The other reason is that not everything we need to do need to be based on randomized prospective studies. Many of the things that we do today is not based on randomized prospective studies. For example, hand washing was an observation that by Dr. Semmelweis. Wearing gloves during surgery was another one of those observations. In fact, discovery of penicillin was in itself an observation. Other reason is there's such a state of ethical issue called equipoise. If you believe something is right, then randomizing your patient to something other than that particular procedure may not be ethically right for you. So if you believe one-stage exchange is the right operation, randomizing them to two-stage exchange perhaps meets the issue of equipoise. That's why Thorsten and I put together this second international consensus meeting in 2018. This time we had more people, more societies represented, almost 900 delegates from almost 100 countries and societies. And the process that we followed in 2018 was exactly the same as 2013. We used the Delphi method. The actual process of consensus had started back in August of 2016, and it took us 2 years to go through all these various steps involved in the Delphi process. This slide highlights all the Delphi process that we had to pass, and it was a long journey before we got to the final document. I won't bore you with the details, but basically we had to go through all the publications related to orthopedic infections. And as you know, this time we also had arthroplasty and other subspecialties in orthopedics covered. And we had to have the document created. Then we had a face-to-face meeting, and even during the meeting, we had to change quite a few things. There were huge debates, quite a lot of things that was going on. And eventually, we had to put these recommendations to a vote by delegates using the audio response system. These are the number of questions in each subspecialty that we covered. And as you can see, all the subspecialties, with the exception of hand, were also discussed and covered during the second international consensus. What did we accomplish? The whole document is obviously on the website and also on the app. I hope you all have access to it. I will give you the information shortly, but let me give you some brief examples of what we accomplished. I think you can divide the questions, and this is what we did on the day as well, into 4 different categories. They're clinically important with high degree of evidence. They're clinically important with low degree of evidence. They're clinically less important with high evidence, clinically less important with low evidence. So example of a clinically important high evidence is the definition. What is the definition of PJI, and what criteria can be used for diagnosis of periprosthetic joint infection? This is an area where there is meta-analyses and other types of studies have been published in the past. And as you know, the international consensus definition now is based on a scoring system and not the criteria that we had in the past, with each minor criterion getting a specific score based on pretest probability and also their performance. So here you'll see that serum C-reactive protein or D-dimer gets 2 points. Elevated ESR gets only 1 point. And I think there's plenty of evidence to show that ESR is not as significant as CRP. In fact, most European centers, including Thorsten, they most of the time don't do ESR. Elevated white cell count is the same as elevated leukocytoesterase, is the same as elevated alpha defensin. Any of these tests would get 3 scores. Now, if the synovial blood cell count is elevated and alpha defensin is positive, that's still 3 points, not 6, because it's or, not and. And then the rest of them are here. It was discussed extensively. There was quite a bit of debate. And as you know, most of you were there. It only reached 68% agreement, mostly with the Europeans being worried that this definition may miss a lot of so-called slow-growing organisms, etc. But actually, the fact is that this is much less likely than the MSIS criteria to miss some of those clinically silent infections. And then we, of course, talked about the algorithm. This is the algorithm for diagnosis of infection. So if you look at this algorithm, this is based on the American Academy, and I may take 1 minute just to sort of highlight the important areas. It is based on 3 things. One is serology, 2 is aspiration, and 3 is intraoperative findings. So you would do ESR and CRP, maybe D-dimer, if you're a believer in it, maybe fibrinogen, whatever it is. And then if they are elevated, or if they are normal, and you have a very high index of suspicion for infection, then you would move to the next step. The next step would be aspiration of the joint. Again, the second step in diagnosis of infection is aspiration of the joint, not CT scan, not bone scan, not PET scan. So you would aspirate the joint, you would send it for synovial white blood cell count, you would send it for culture, you would send it for synovial PMM percentage. Some of us may also do leukocytoesterase test. Some of us may also send it for alpha defensin. Again, international consensus is not mandating that you perform a biomarker test on the synovial fluid. It's telling you that it would provide additional information if you wish, but in terms of the scoring system, it doesn't make a difference. When the alpha defensin is positive, white cell count is elevated, you only get 3 points. Again, just repeating this important point because I think that was misinterpreted by some of the delegates who were attending the meeting. So if the aspiration is negative, in other words, you cannot get any fluid, you have 2 options. One is to bring the patient back on a different date and try reaspirating, or you can move on to arthroscopic or open biopsy of the joint to get fluid and or tissue, your choice. If you don't want to do surgery, then you could potentially consider other types of investigation. Now, if the synovial aspiration is negative, but you have a high index of suspicion for infection, you may not reaspirate the patient, but do the aspiration during the surgical procedure. So again, serology, aspiration is negative, reaspirate, or you can take the patient and do an open biopsy. So nowhere in this algorithm do you see the CT scan, PET scan, or more importantly, bone scan anywhere in the top category for diagnosis. And it's a shame because we actually see a lot of people, surgeons around my neighborhood, that will order a 3-phase or leukocyte labeled bone scan, and they haven't aspirated the joint. And that is really not the way to approach this. Now, there is a PGI DX app, which is actually housed inside the ICM Philly app. And this app will take you through the algorithm. And I think it's very important because it will tell you what to do next based on the results that you provide. Another question that we'd asked is what modifiable and non-modifiable risk factors exist? Again, quite a bit of publications related to this particular issue. And modifiable risk factors include high BMI, smoking, alcohol consumption, diabetes, malnutrition, and other medical comorbidities. And again, here, very high agreement, 98%. Venous thromboembolism was discussed, and I know I've been to India. We've talked about this a few times, and I'm delighted to see that India is also moving in the right direction by moving away from aggressive anticoagulation and using less aggressive anticoagulation such as aspirin. Here we asked whether there is a direct correlation between the type of VTE prophylaxis you use and the subsequent risk of SSI and PJI. Quite a lot of studies done, including 2 randomized prospective studies. And the answer is yes. In a majority of these studies, it is shown that the more potent or more aggressive the anticoagulation agent is, the more likelihood is for an SSI or PJI. Is there a correlation between transfusion with allogenic blood and subsequent risk of infection? The answer is yes. Allogenic blood transfusion does increase the risk of SSI and PJI, hence the need for blood conservation, addressing anemia before surgery, etc. Another category, again, another set of important clinical questions. Is 1 dose of preoperative antibiotic adequate for patients undergoing total joint arthroplasty? As you know, recently WHO and CDC are both recommending a single dose of antibiotics for clean surgical procedures, which actually includes joint arthroplasty. And the recommendation was, despite the current guidelines from CDC, we don't believe there is adequate evidence to stop giving our patients 24 hours of antibiotics, in other words, 3 doses of cefazolin. And that was, again, very high degree of agreement. I would like you to know that there is a randomized prospective study underway in the United States. We've been part of that study. It's coordinated by Duke University, and it's funded by American Association of Hip and Knee Surgeons. And this study will hopefully address the question for us as to whether we need 1 dose or 24 hours. But until such data, level 1 data, emerges, most institutions, including mine, continue to administer 24 hours of antibiotics to our patients. What about type of anesthesia? Does that make a difference to eventual rate of infection? The answer is yes. The spinal anesthesia appears to lower the risk of SSI and PJI. Your guess is as good as mine, and there's multiple speculations, but I believe the most important is the fact that with regional anesthesia, you're able to do hypotensive anesthetics, potentially reducing operative time because the muscles are not as tight, and clearly reducing blood loss, which are both linked to a subsequent risk of SSI and PJI. Laminar flow. I know this is a question that all of us keep asking on a daily basis. What type of operating room do we need to be in when we are performing arthroplasty? Is there a link between the use of laminar flow and subsequent infection? Not much studies. There's few from, as you know, registries, including the New Zealand registry, that show the higher incidence of infection in laminar flow rooms, especially for hips. But here, I think the understanding and the recommendation is that although you do not need to have a laminar flow room to do the arthroplasty, you need to have a room that has positive ventilation system and provides as much of clean air as possible. That's basically the recommendation of consensus. How about the use of antibiotic-loaded cement during the primary joint replacements? No proper randomized prospective study. 1 Canadian study was underpowered that showed no difference. There has been a lot of debate on this particular particular issue. In fact, we had to change the question because the initial question that we put in was not passed. And the bottom line is there is really no high-level evidence to support the use of antibiotic impregnated cement during primary total joint arthroplasty, but you may want to consider that for high-risk patients. So this was the initial recommendation. There's no conclusive evidence to demonstrate that routine use of antibiotic impregnated cement in total joint arthroplasty reduces the risk of subsequent SSI and PJI. Recent high-level evidence and registry data has not demonstrate the reduction in SSI PJI. This is talking about the Australian registry. So this was actually discussed. This was the voting. And obviously, this question still remains unanswered with this type of a voting. So we had to go back and change the question and the answer. Is there a role for the use of antibiotic impregnated cement during total joint primary joint arthroplasty? And this was the recommendation. Antibiotic impregnated cement may be used during total joint arthroplasty to reduce the risk of infection. The benefits of antibiotic impregnated cement versus its cost and potential for adverse effects may be justified in high risk patients. And here we had 93% agreement. There were other questions that are maybe not as clinically important, but nonetheless something that we continuously ask. Should you be changing the drapes during irrigation debridement? I went to see Thorsten Gehrke in the clinic, and I noticed that during their one-stage exchanges, they would take everything out. They would rescrub new instruments, etc. And that's how I'm doing the one-stage exchanges now. The question was, does that also apply for irrigation and debridement? Once you've done your irrigation debridement, should you be changing the drapes? Again, not many study on this point, and basically consensus says it hasn't been investigated. This issue has not been investigated. It should be done at the discretion of the surgeon, 94% agreement. What about number of individuals in the operating room? Does that influence the risk of subsequent infection? The answer is yes, absolutely. The number of individuals in the operating room during joint arthroplasty is directly correlated with the number of airborne particles in the OR, and hence it can lead to increase in infection, 98% agreement. And finally, maybe clinically less important question with low evidence. Should surgeons and OR personnel wear a mask and a cap in the operating room? I know that, remember, this question was asked before the pandemic issue. There's been some studies showing that masks, even the surgical mask, and they don't have to be respirator masks, reduce the number of droplets and hence may be important for transmission of COVID-19. But the question is, should the masks, do the masks reduce the incidence of bacterial infection? A long answer here, but the bottom line is, even though this question and this particular issue has not been investigated by level 1 studies, under the circumstances, it is advisable that the surgeon wears a mask and obviously a surgical hat. 98% agreement. Other questions like, what is the definition of sinus tract? It's interesting. Everybody has a different definition of sinus tract. And especially because sinus tract is used as a major criterion for diagnosis of periprosthetic joint infection, we all need to understand what we mean by sinus tract. And I've heard a lot of people refer to this as fistula. Fistula is an abnormal communication between two epithelial surfaces. Sinus tract is a communication between a cavity and an epithelial surface, usually outside in the skin. So basically it means there's a direct track from skin all the way into the joint. If there is not such a communication, then it cannot be by definition called a sinus tract. 97% agreement. The document has been published. The arthroplasty related questions have been published in the Journal of Arthroplasty, thanks to the editor-in-chief, Dr. John Callahan, who facilitated that potential publication. The publication is also in the form of a book that's been translated to numerous languages, and it's been distributed across many, many meetings. These are the languages so far that have been translated in green, and they are all on the website. We have disseminated the material, but most importantly, I think the material is available on ICM Philly app. And here, if I may show you, that's the PGI diagnosis app that's inside the ICM Philly app. In the middle, there is another app called Pgi Risk Calculator, which actually tells you the potential risk of infection for your patient. Very useful. And then very recently, last week, we added another app to this. It's the DARE calculator. if you put in the information related to your patient with acute periprosthetic joint infection, it will tell you the likelihood of failure of the procedure if you were to do irrigation and debridement. Very useful. It was the winner of the Hip Society Award this year, a multi-center, multinational study that was just recently completed. And I personally find that app very, very useful. I hope if you don't have access to ICM fully, please download the app, and everything relevant related to our mission is in there, and we continuously update it. Every week there is a paper of the week that we also put on the website, and documents such as the one that we worked on recently with Thorsten on elective surgery during COVID, for example, is there also. I want to thank you for giving me the opportunity to present to you this material, and I will stop here. Thank you.
Thank you. Thank you, Professor Parvizi. That was a great lecture on the recent recommendations in 2018 meeting. We'll invite questions a little later after Professor Gehrke's talk. May I invite now Professor Thorsten Gehrke to deliver his lecture on one-stage revision. Is it the new gold standard, hopefully?
So can you hear me now?
Yes, please.
Okay. So again, thank you very much for this very, very kind invitation. Usually I prefer to come to India in person, but now I'm sitting here in my office. It's 2 o'clock in the afternoon, and but I'm very glad to see you all and to get the opportunity to talk a little about one stage. I did many talks about one stage during the last 20, 25 years. But I'd like to show you some new results about one stage, new papers, new publications, and probably, I know it's a little bit provocative, the new gold standard, but at the end of this talk, probably you will see that this is not too provocative at the moment. So Jay did a very nice talk about how can I proceed here?
You can click on the lower left corner of your screen.
Okay. So as we all know, and as you have heard from Jay already, the worst complication in total joint arthroplasty is PGR, which is really a life-threatening complication. PGI is worse than some cancers, worse than breast cancer, melanoma, Hodgkin's lymphoma, or testis cancer. So it's really a very, very severe complication. And we have heard a lot about diagnosis yet, about environment, how to treat it. And I'd like to talk now about treatment. As we all know, we have many, many options to treat a periprosthetic infections. Some of them are very, very favorable, and some of them not, like resection arthroplasty, amputation, or lifetime antibiotic suppression. So the godfather of the endoclinic was this man, Professor Buchholz, who did the first total hip replacement in Germany 56 years ago. Here you can see the X-ray. And he was a genius guy. He did a lot of joint replacement already in the 60s. His main problem, as you can imagine, was the periprosthetic joint infection, of course, where he reached in the peak more than 6%. So he was thinking about this issue, and he came to the idea, and this is a letter that he wrote 51 years ago in 1969 to the company Kulze, who manufactured the bone cement during this time. And he asked the company is it possible to admix antibiotics to the bone cement? And they agreed. They did some work with him. They developed bone cement, which included first penicillin and then erythromycin, and then they ended up with gentamicin. And on the right side, you can see how he reduced his infection rate at the beginning of the 70s, almost down to 0.5. The goal was not to kill the bacteria in the situs. The goal is mainly of antibiotic-loaded bone cement to protect the new implant from recolonization of bacteria. So in the endo clinic, since that time, we developed the concept of the one-stage exchange. Buchholz started with the one-stage exchange 50 years ago. And in the meantime, we do about 84%, 85% of all our infections in the one-stage procedure, and only less than 10% in the two-stage procedure. So our protocol is, if we have a very early infection, an immediate infection, a direct post-op infection, which means it occurs less than 3 weeks after implantation, and where the biofilm is really very, very vulnerable. In this early biofilm, you can disrupt and you have a chance to perform some kind of DARE. DARE is a very new term. 20, 30 years ago, we did exactly the same as it described in the English literature, but we called it irrigation and debridement. And of course, additionally, systemic antibiotics. We are very, very strict in our protocol. So every infection, periprosthetic infection that occurs longer than 3 weeks after implantation of the implant, we go for an exchange, for a septic exchange. This is in clear contradiction to the philosophy of many, many other groups all over the world, mainly in UK, who are talking about DARE a lot at the moment, and especially the Oxford data show that DARE could be done even in a long term and after 1 or 2 or 3 years with quite good results. But they also say, as earlier you do the DARE, as better are the results. Unfortunately, all over the world, we see cases like this young lady who underwent 87 revisions without removal of the implant, and she was suffering from periprosthetic joint infection for more than 6 years. Or the surgeon is not able to remove the implant, as you can see here, case from Italy where the surgeon was not able to remove the distal cement glass revision stem, and he put on a spacer like this. He was not really radical. He didn't really exchange the prosthesis. He didn't really remove the foreign material. So I was forced to do it in that way. So mainly J. Parvizi and some others published data about the control rate of late chronic infections by retention of the implant, by not removing all the foreign material. And you can see here the results by doing these in the literature are very, very poor, 18 to 36%. So the question now is, should we go for the one stage or better for a two stage? Is one method probably a little bit safer than the other method? All over the world, the two-stage exchange is still the golden standard. Nobody knows really what a golden standard is, but everybody is talking about it. But the whole world, or most parts of the world, are doing the two-stage revision. But I put a big question mark behind it now. There are many pros and cons between one stage and two stage. In my opinion, two stage has much, much more pros than cons. Surgical risk is lower, functional impairment is lower, financial burden is much lower, compliance and satisfaction rate of the patient rate is very high. Our therapy algorithm in the endoclinic is quite clear. So first of all, is there a major biofilm? If you say yes, then the pathogen is known and local antibiotics are possible and a radical debridement is possible. We go for the 1 stage. If we have a no in this algorithm, we go for another kind of therapy there or 2-stage exchange. Our key of success in a 1 stage is, and this is the prerequisite for a 1 stage, you have to do a very, very probably preoperative diagnosing, and you have to know which germs are responsible for the PGI. If you know the germ and if you know the susceptibility of the germ, in our opinion, you can go for the 1-stage exchange. If you do not know the germ, you should perform a 2-stage. Here are the key steps of a 1-stage exchange. We excise the old scar. We do it in a very well structured manner. The debridement, radical synovectomy, of course, remove all foreign material, perform a radical debridement of the bone, use pulsatile jet lavage. And in our opinion, and this is changing a little bit during the last years, in our opinion, you should use antibiotic-loaded bone cement. Here's our protocol. The patient is coming to the admission 2 days before the surgery because many of those patients are multimorbid. So they need another day for preparation from the internal medicine, from anesthesists and so on. And then we do the 1-stage exchange on the 3rd day. The dismission is 14 days, in average 14 days later. After 10 to 12 days, we stop the systemic antibiotic therapy and remove the suture. Here, a short video for how we are doing it in the hips. So you have to remove, again, you have to remove all foreign material. We prefer to remove the stems in the endofemoral way. We don't like the ETO very much because the integrity of the bone, in our opinion, is mandatory. After removal of the last biopsy, we start with systemic antibiotics, and as Jay already mentioned, we change after debridement everything. We change the gloves, all our gowns, everything, and the instruments, and then we are going for reimplantation of a new device with antibiotic-loaded bone cement. And that's all. I show it shortly in a knee. It's the same philosophy. First of all, radical debridement in a standardized manner. So we start anterior, then medial, then lateral, remove all foreign material, even little cement pieces, remove the tibial tray, of course, and if there's some screws or cerclages or something like this, they have to remove it as well. Clean it, clean it, clean it, debridement, 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 debride also the posterior capsule very thoroughly, start with systemic antibiotic, change everything, and then reimplantation of a new device. And we are with antibiotic-loaded bone cement, and this is probably a little bit too much, but we believe in hinge implants, and so we are using in our 1 stages of the knees always a rotating hinge knee. So 1 stage means radical debridement, usage of pulsatile lavage, and a very, very good and microbiological advice, because you have to tailor the antibiotic mixture in the bone cement to the germ and to the susceptibility of the germ. So it means you cannot use always the same antibiotics in the bone cement. You have to tailor it on the susceptibility. So, and you need a multidisciplinary approach. This is a top secret. This is really the secret after the behind the success of a one stage. You need a good microbiological lab. You need a good cooperation with the microbiologist or infectiologist. You need a very good nurse team. You need a good anesthesiological team. And you need, of course, skilled and trained surgeon. And this is probably the most important point, because you need training in doing septic revisions. We have some indications for two-stage septic revisions. Of course, if we do not identify the germs pre-operative, if there are no local antibiotics available, if the radical debridement is not possible, then we go for a two-stage. I'd like to show you shortly how we are doing the two-stage at the moment since 3 years now. And I love this concept because it's a very safe concept. We all know that spacers, any kind of spacers, usually in the two-stage exchange could lead to dramatic complications, fractures, dislocations, and so on and so on. And here is a girdle stone after removal. Here is another removal, and you see here there's a huge, if you do it in that way with a girdle stone situation, it could develop a massive bone around the joint, and then you have to change it. Here is a typical example: infected cementless joint replacement, hip arthroplasty. The germ was not identified, and we do our two-stage procedure in a, I would say it's a 1.5 stage exchange. We do our spacers with a combination of a badly cemented stem with a dual mobility inlay. Just the inlay of the dual mobility cup. I show it in this video shortly to you. So first of all, you put in the antibiotic-loaded bone cement in the acetabulum. During hardening of the bone cement, during polymerization of the bone cement, you move the trial of the dual mobility inlay liner, that's a trial, until the cement is really hard. So you create an antibiotic-loaded bone cement shell in your acetabulum, as you can see here. And then you put in just the liner. You would cement the stem in a very late, bad cementing technique, quite late, not after 2 minutes, after 4 to 5 minutes. Then you put in a liner on it. And this is a very safe procedure. And we did, at the moment, we did 75 of these spacers without any kind of complications. The patient can have full weight bearing from the first day. We haven't seen any dislocations, spacer dislocations, or anything else. So, but let's go back to the one-stage versus two-stage procedure. If you look at to UK, we must say that there is an increased use of single-stage revision in UK. In 2005, just 17% of the surgeons were using the single-stage revision. In 2014, they were already used almost 40%, and now it's almost 50%. Because the morbidity in the two-stage approach is quite high. The 90-day mortality rate is about 2.6%, and major complications were seen in more than 15%. The complication rates of a two-stage exchange are significantly greater than some very big surgeries. That's a paper that was a paper of the week 1 year ago, the ICM paper of the week. It's coming from Michigan, from a US, where almost everybody is performing the 2-stage, except J, fortunately. And they concluded in this paper, they compared all the management, the life quality in 1-stage and 2-stage, and they concluded that the 1-stage revision produced greater health utility. Also, and that's very important, also in difficult to treat organisms, including MRSA. And additionally, it's a very cost saving. In the consensus, you have heard a lot about it. I don't want to reply it. We said that the 1-stage procedure remains a viable option for the management of chronic prosthetic joint infections, except in patients with of systemic sepsis, extensive comorbidities, and with resistant organisms or culture negative. So the multidisciplinary approach is very, very, very important. You have to look at the patient, of course, first. And if you see the patient-related risk factors for periprosthetic joint infection, these are data from UK on 512,000 patients. There are the main risk factors were BMI over 40, diabetes, rheumatoid arthritis, depression, steroids, and that's very important, previous joint surgeries. So I'm not going, I'm skipping this against, and the multidisciplinary team, the cooperation of all the involved subgroups is very important. Knowledge of the germ is important. You need a very, very good infrastructure. And that's a great paper from Haddad's group, where he described this multidisciplinary team. So another point is I mentioned it's skilled and trained surgeons. Of course, the surgeons is very important. The surgeon must be able to perform a radical debridement. What is radical? I mean, really, that's the most difficult part of the surgery, to decide is this tissue infected or not. You have always to find the interface to the healthy issue. Radical means really radical. If it is the whole bone is infected, you have to remove the whole bone. So primary fixation is important, of course. If we are going to the literature now, what are the more recent ones? We published a lot about this, about blood loss. Blood loss was a cooperation with Jay's group in Rossman. Blood loss is much, much less in the 1-stage group compared to the 2-stage group. Of course, then we looked after the in-hospital complications after 1-stage and 2-stage. And you can see here that the surgical morbidity was almost the same, but the medical morbidity and mortality, it was much, much higher in the 2-stage. You see our mortality rate was 2.27%, and for the 1-stage only 0.5. Okay, this is a very biased study, but it's interesting. What's about our long-term results, 10-year results in our hands of the 1-stage exchange is about 94% after 10 years, but you have to notice that the revision-free survival is just 76%. So we looked after the predictors of failure of at a 2-stage. That's clear. There, Jay's group published medicillin-resistant organisms, culture-negative organisms, and increased reimplantation operative time as main risk factors for failure. And then we asked ourselves, why do 1-stages fail? We published it in GBGS and Clinical Orthopedics, 2 publications. We looked after almost 700 1-stages in TKA. I make a long story short. The most failures happened after between 6 months and 2 years. Here are the top 3 causes for failure: recurrence of infection, aseptic loosening, and patellar problems. But why did they fail? Here I show you enterococci are very, very highly for failure prior 1 stage or more than 4 surgeries before. And interestingly, isolation of streptococcus is also a main reason for failure. So this is according to another paper from Ma, who described as well Enterococcus species as a very, very difficult to treat germ, gout, surgery time, and BMI here. And here some others who describe streptococci as well as. So the last publications, I go very, very quickly through it. We published our results, 10 to 14 year results in patients younger than 45 years in hip arthroplasty, and the irrigation rate was 96%, but the overall survival rate again was just 77%. In the knees, here the paper from France, irrigation rate in comparison is 1 stage much better than in the 2 stage. This effort group concluded similar results in terms of eradication rates and offering the advantage of a unique surgical procedure, lower morbidity and reduced costs. Here another paper from Denmark, which concluded that the patients treated with cementless 1 stage revision has a very marked increase in life quality terms. And I could go through the whole literature here from the Ortho Carolina group in US, who mentioned that 1 stage is a wonderful procedure, but not very cost effective for the surgeons. Here, another paper from Norway, 1 stage, again, 2 stage, much better results for the 1 stage group in the registry. Another paper from France, 90% remission rate, better than the 2 stage. And I could go through all these literatures and papers, and most of them are coming to the conclusion, as you can see here, for example, and from this, again, from France, 1 stage exchange seemed to provide better results with less reinfection and fewer complications than 2 stage. So I ask you again, is the 2 stage really still the golden standard? I'm not sure. Thank you very much.
Thank you.
Hello?
Thank you, Professor Gehrke. That was an excellent exposition of 1 stage revision. Now we have plethora of questions from our people here, but before we start, let me ask one question to Dr. Parvizi. Now, metal on metal hips and reaction metal on metal in a local tissue reaction mimics infection in a joint replacement. The question is, how do you differentiate this adverse tissue reaction and infection in a case who has undergone metal on metal preoperatively as well as intraoperatively?
Yeah, thank you, Dr. Mohanty. Yeah, very challenging situation. Preoperatively, your workup for infection is no different for metal on metal than regular hips, with 1 or 2 small exceptions. So you would still do ESR and CRP, and if you have a high index of suspicion, or if ESR and CRP is abnormal, you would aspirate the joint. Now, with metal on metal, when there's adverse local tissue reaction, there's usually quite a bit of fluid either in the joint or adjacent to the abductor mechanism where the destructive process is taking place. So usually these hips are either aspirated under ultrasound, or a Mars type MRI is done on the metal on metal type. So either way, you would then aspirate that joint, you would send it for culture for sure, you would then send it for biomarkers if you wish, but cell count and neutrophil differential. There has been some suggestions that you should perform a manual cell count on this fluid because the automated process may pick up the iron metal particles as a cell and give you a false result. That doesn't actually seem to bear weight based on 2 recent studies. Either way, whether you want to do manual or automated, you should definitely analyze the cells. The threshold for cell count and neutrophil differential for an ALTR situation is considered to be the same as other scenarios for infection, until maybe further evidence emerges in the future, in which case we'll re-examine that threshold. So the one very important issue that exists is that if you're operating on an ALTR situation, and as most of us have done, the fluid is very purulent, is suggestive of infection. And that can sometimes mislead us in the process to think that it's infected when it may not be. But the flip side of the coin is that the incidence of infection in ALTR cases is much higher. It's about 8 to 9% based on some literature recently, and even in some series up to 30%. So just because you identify ALTR, it doesn't mean you've ruled out infection. And remember that ALTR can look like infection and it may not be. So it's sort of very complex process. To give you a very quick answer, what do? ESR, CRP, I aspirate them regardless. I actually get an MRI to see if there's destructive process around the abductors or not. If there's destructive process, if I am worried about the type of metal components that are in there, I would revise them anyway. And then at the time of surgery, I would send a sample for cell count, neutrophil differential. I do leukocyte esterase. We published on this. Leukocyte esterase has about 92% sensitivity for picking up infection in the presence of ALTR. I would send it for culture. If I'm worried, I would remove everything, put a spacer, wait for the culture, and go back early and put them in. But if I think that we've ruled out infection, I would then remove everything and redo them at the same time. I know this is a long-winded way, but to summarize, you should work up all ALTR cases for infection because the incidence of infection is very high in these patients. Seeing pus during surgery doesn't necessarily mean they are infected because ALTR can lead to a destructive process that makes it look like pus.
What about leukocyte esterase and alpha defensin in?
Leukocyte esterase, alpha defensin is not proven to have a role in diagnosis of ALTR. That's one exception to the ALTR. I know Thorsten has some experience with the new tests. I don't know if the lateral flow test has been validated for this particular application, but with Cleveland Clinic, we wrote up our results with leukocyte esterase for ALTR, and it has 92% sensitivity. So I would do leukocyte esterase.
Yeah.
Can I add something?
Yes, please.
So I sign everything what Jay already said. Regarding metallosis, alpha defensin could be very misleading because if you have some kind of metallosis or metal wear, not even if it is not ALTR, you could have an increased alpha defensin value. So for example, today I operated a dislocated acetabular component, which dislocated up to the iliac crest. It was a lot of metallosis. The patient had a alpha defensin of 3.5. The cutoff is 1.0. So I punctured her last night again because I was not sure. Everything was normal. It was clear fluid, leukocyte esterase was negative, cell count was negative, and PMN was negative. So only the alpha defensin was higher. So don't be misled by false positive alpha defensin. It's in some cases not an infection, it's some kind of metal wear.
Okay, thank you. One more question that when you add antibiotics to the cement, do you add antibiotic powder to the cement powder first, then mix it thoroughly, then you add the liquid? But some people tell that you first, add the liquid to the cement powder, and while the cement polymerase, then gradually add antibiotic powder so that the antibiotic properties are not affected.
So yeah, very good question. Thank you so much for it. We call it pharmaceutical mixing. That means we have the powder and we put a little amount of antibiotics into the powder, mix it, then another little amount of antibiotics, powder to powder, mix it in small doses, step by step. So you get a more homogeneous distribution of the antibiotics in the bone cement powder. And if you are, when you finished with your mixing, then you put the fluid on it. And that's the way.
Okay. Is there any question from the faculty, or else I'll go to the questions from our participants?
Bondi, I have a question.
Yes, Vijay.
To Thorsten, but Thorsten has just left. Yeah, maybe Rajiv, your question is to whom?
My question is to Thorsten.
Okay, you just.
Sorry, I'm here, but they had some kind of an emergency. So,
Thorsten, I have a question for you.
Yeah.
And Jay can also add on. When we do the femoral revisions in THR, one stage is fine. But when you do a cemented revision, when there is not a good cancellous bone for you to cement, there's so many published reports saying that they do very badly. But only in the endoclinic, we're able to cement in a very, bad cancellous bed and all that, cortical bone, and they're able to get away with it. So what's your thoughts on that?
Yeah. Very good question, Vijay, because this is, you pointed exactly the weak point out, because that's a weak point in one stage exchange or in hips. As you said, after removal of the former prosthesis, your bone bed, your cancellous bone bed is really poor. So you re-cement in a poor bone bed, and this could lead to very, very short survival of the stem, as you said. We do it, and we published our data. So we have, after 10-year, a loosening rate of about 10%, 10 to 12%. But this could be a very good argument, first, for a two-stage in the hips, because you can re-implant a cementless revision stem. You have the chance to re-cement in the second stage a cementless revision stem, or we see more and more publications. I showed one of them from Denmark, where they use cementless stems and partially cups in one stage exchange. I think it's quite brave, but they report very good results. There's another group who is doing it in Vienna. There's another group who is doing it in Norway. So I think
it's, you said that's a weak point.
I think we
still use antibiotic loaded bone cement.
Jay, what are your thoughts on that?
Yeah, Vijay, thank you for that question. I agree with Thorsten. But in the US, all the revision hips are uncemented, and majority of revision knees are cemented. So if we're doing one stage, which I have done, with the knees, I add the same amount of antibiotics that the endoclinic protocol asks for. But in the hips, we do not do cementing. We have been doing uncemented hips. We have Tom Ferring is doing that one stage versus two stage randomized prospective study. The results will be out soon. But cementing the hips was not part of that protocol. Not because we're disrespecting what endoclinic has been teaching us, but for surgeons who haven't been doing cemented revision hips for them suddenly to start doing cemented because of that antibiotic delivery issue, we were worried that we were going to get terrible results. So we have continued, and I guess we will see whether the hips have a higher failure after one stage when antibiotic cement was not used versus the knees when it was used.
Thanks very much.
Thanks, BJ.
Yeah, Rajiv.
Thank you, Shubhranshu. My question is to both Jawad and Thorsten. Thorsten, you showed us very good presentation of your one-stage revision. What we understand is that you're using in most cases the rotating hinge. What is the extent of your, because one stage is how much debridement, how much of the tissues, dirty tissues you remove? Do you take off the whole medial collateral and lateral collateral, significant part of it? Is that the reason of your success? I mean, in most of our hands, the one-stage revision is not as successful because probably we try to retain some of the doubtful tissues.
Thank you so much, Rajiv, for this very important question. So first of all, I think, and the secret of our success is the radicality of debridement, as you said. So when we have visiting doctors here or fellows from other parts of the world, they were also always completely surprised how radical we are. And that's the reason, probably sometimes we are a little bit too radical, could be, but that's the reason why we have to use hinge knees, because we involve in our debridement usually the medial collateral ligaments. So that's the main reason why we do it. So most of the infections, I would say an 85% of the infections, the collateral ligaments are involved in the infection. Of course, there are amount of, let's say, 10 to 20% where we have a very low-grade infection where you could use another kind of implant like a PS design or a CCK design, of course. But we have our protocols and we have, I believe, in standards, to be honest, and that's our standard to use a rotating hinge knee.
Okay.
Yeah,
Abhinav, we have questions from YouTube. Unmute yourself, please.
Yes, sir. We've got a question for Dr. Thorsten from YouTube, sir. Dr. Kushmukhi asked, how many one stages do you accept in a patient? And what is your indication for a, suppose you have one stage failure, one stage has a failure, then when do you turn over to a two stage?
Good question. Practically, we do usually not more than 2 one stages. So if we have a failure of one stage, many times we repeat it, another one stage. But if we have 2 failed one stages, we remove everything and wait to perform a 2 stage.
Yeah,
Okay.
thank you, sir.
Before next question, Krishna, yes, your question. You had a question. Unmute yourself, please.
Yeah. So my question is to Thorsten. You showed that there is a 9 to 10% failure of your one stage knee revisions. So what happens to them? You have put in a cemented hinge prosthesis. So what is the next stage for them? So how many of them actually end up with a further revision, or what is the option in them?
It's almost the same answer. So one failed, if you have quite good bone and soft tissue, after one failed one stage, we do another one stage, usually. If we have a big amount of bone loss, if the soft tissue is weak, we are not going for another one stage, then we go for a 2 stage. And we use always, and this is also part of our philosophy, we use in a 2 stage in knees always static spacers with rods in the rods in the tibia and in the femur. So if one stage is knee failed, remove it, do another one stage if the circumstances are allowing it. If not, due to bone or soft tissue defect, we go for 2 stage.
There's one question from YouTube by Dr. Sam Mukhi. The patient is doing well with the spacer, and then she doesn't want a revision. Then how long you want to pull on?
That's a very good question. So you have seen our spacers, and you can imagine that some patients are very happy with the spacer. We had, usually our interval is about 2 to 3 months. We have quite long interval between the 1 to 2 stages. We had one patient who, due to cardiac problems, he had the spacer for 1.5 years, and he was absolutely happy. But interestingly, and the most interesting part is, in this kind of spacer, I expected a lot of third body wear because the inlay is moving in the cement shell. So we send it to the lab, we send it to the pathologist, and he couldn't find any wear particles. That was very interesting. So usually we do it just for 2 to 3 months. You can leave the spacer longer, up to 1 year, but I do not recommend to use it as a lifetime kind of arthroplasty.
Jay, would you like to add? What about in your practice? Do you how long do you leave these patients with spacer if they're happy about it and moving around, don't have pain or instability?
Yeah, great question. I don't have a specific metric for time. It's individualized, but we do have patients who actually had an articulating spacer and who never want to come back and get reimplanted. We have them many years out. But as Thorsten said, you do worry about the bone loss in this situation, and possibility of dislocation and dislodgement of the spacers. So I start to get a little nervous if it's been there more than a year.
Okay.
Can I ask a question?
Yes, please.
Yeah. What is a post-op protocol of antibiotic 1 stage and 2 stage, or any standard protocol post-op IV antibiotics?
I can say it for the 1 stage, our average. So there is no standard post-op protocol. It depends on the patient, it depends on the germ, it depends on the susceptibility of the germ, the wound situation, but average, it's about 14 days systemic antibiotics, and then we switch to orals for another 6 weeks at the moment. 3-4 years ago, we recommended just systemic for 12 days and nothing, but we changed a little bit our mind. So 14 days systemic, 6 weeks orals. In the 2 stage, it's the same, depends on the situation, on the length of the interval, but we are doing 2 stages only in selective cases. And according to Jay's work, who did it with Craig de la Valle, we at the moment prefer longer antibiotic therapy up to 3 months after 2 stage. Jay, what's about you?
When you decide to give 6 weeks of IV antibiotics?
No, 2 weeks.
When you decide to give 6 weeks of IV antibiotics? Yeah, but
very rarely. Okay.
So not required.
We don't know. It's very, very rarely. I cannot really remember a 6-week IV procedures. We had one case with tuberculosis who received, of course, for a long time IVs, but usually not.
Okay, great.
Jay, what is your protocol?
Yeah, we similar. So with the 2 stage, we would give them 4 to 6 weeks of antibiotics, and that can be intravenous if there is no orally available agent against that particular organism. But if there is an oral agent, then they would receive oral antibiotics. So for example, Pseudomonas, they would go on fluoroquinolones. Some of the MSSAs may be treated by oral antibiotics when they leave the hospital. Then we would have the reimplantation. After reimplantation, if the culture is negative, they would receive 3 months of oral suppressive antibiotics based on that study that Thorsten just mentioned. If the culture is positive, based on a paper that we wrote and Charité group also confirmed, the failure rate is really high in these patients, so they may benefit from an additional intravenous antibiotics for 4 weeks. The one stage, we're following the endoclinic protocol. They will receive 6 weeks of complete antibiotics, again, intravenous if there is no oral agent, but oral antibiotics also. And then after the 6 weeks, we stop. We don't give them any further. You know, Mark Scarborough and the group from Oxford just published a very interesting paper that showed there was no difference between oral and intravenous antibiotics in treatment of these patients. Granted, it was a very heterogeneous group of patient population, but it's possible that we've been a little too aggressive with administration of intravenous antibiotics, and time has come for us to think about at least switching them to oral after a week or so of intravenous antibiotics if an oral bioavailable antibiotic exists.
Okay. Dr. Sanjeev Jain?
Yeah. So what's your percentage of recurrence or reinfection rate in 1 stage or 2 stage? And do you have any very specific protocol to pick up this early infection, recurrence?
Jay, would you like to take that?
Sure. After 2 stage, all comers within the first 5 years is about 24 to 25% failure. And that's a great question, Dr. Jain. We'll come back to defining what we mean by failure, but let's just go through the numbers. So 25% failure within 5 years. 1 stage, I don't know, because we've only been doing them for a year and a half or so now. I think I have done about 21 cases. 1 has failed. The others haven't. So I don't know the right number for the 1 stage. I think I'll let Thorsten answer that question. In terms of what we define as failure, though, you saw the new paper by Yale Fillingham, the MSIS criteria for definition of failure. A lot of people think that retaining an implant is success. But if you look at those patients really critically, some of them are on chronic suppressive antibiotic treatment because there's still an infection. And some of them have loose components, but they don't want to undergo another operation. Some of them has severe functional limitation and pain. So, you know, depending on where you draw the line in terms of defining success, I think that number gets to be higher and higher if you take into account radiographic loosening, take into account the functional outcome, and more importantly, if you take into account the mortality. So, you know, between the first and the second, as Thorsten said, 7 to 8% of our patients die between the first and the second stage. 11% of our patients never come back to get the second stage, either because they're still having the spacer in place, they're not medically fit for another operation, or patients have just had enough and they don't want to do it. So that's really something that I think the orthopedic community needs to become a little more engaged in defining what we mean by failure and success. But if recurrence of infection means another organism or the same organism coming back, florid infection, resulting in another operation, that number is more like 10 to 12%.
Thank you.
Okay, in continuation to that, there's a question from Dr. Suryanarayan that suppose one of the implant is well fixed in presence of infection. Do you tend to take out both of them or try to retain that? What is your take on that? Thorsten, would you like to take that?
Yeah, that's a very, that's a question which is really under discussion at the moment. And I have always my fights about it, especially with the UK groups from London and some other group cities there. So our clear, absolutely clear opinion is you have to remove everything, even very, very, very well fixed implants. And if you are not able to remove them, you have to send them to a center who is able to remove it. Because we do think in the concept of biofilm, we do think in the concept of colonization of foreign material, and nobody can tell me that, or I can really be sure that there are no bacteria going in the interface between the fixed, well-fixed prosthesis and the bone. So I know that many surgeons don't like this philosophy because of the inability to remove some kind of fixed implants. But I don't see any reason to leave a well-fixed implant if in case of periprosthetic joint infections. We remove everything.
Yeah, Dr. Asitsa.
Yeah, my question is, we do more and more joint replacements and we will get infections. As our number of primary joint replacement increases, the infections are going to go up. Do you think that this work of revision surgery, every arthroplasty surgeon should get on with it, or it should be left with a particular center where more and more experience is gathered, more and more patients are referred there, so the outcome from that particular center would be very good? From both of you, please.
In my opinion, we need centers. With every country needs a center, because I mentioned during my talk, you need skilled and trained surgeons. So, and you have these kind of surgeons regarding septic revisions only in centers who are doing 200, 300, I don't know, 500 likely. So, and I don't understand why they do not realize it. So in Spain, they did it. In Spain, they have 4 centers, and every infected patient has to be sent to one of the centers. In UK, they have the same, 5 centers in all UK. Why not in every country? I'm fighting for it here in Germany. We need just 3 or 4 in Germany. We have 80 million. It's not comparable with India, of course. 80 million people, 4 centers would be enough, one in the north, one in the south, west, and east. And in India, the same. I mean, you have all the big cities around India, and why not establish a center in Delhi, a center in Mumbai, a center in Hyderabad, in, I don't know, Bangalore, Pune, I don't know. So, because only if you establish centers, you will get satisfying results.
Okay, Jay, your comments on this, please?
Yes, I agree with that comment completely with Thorsten. You know, I'm not sure if I can add much more to what he's just said. And unfortunately, I apologize very much, but I have a very firm commitment that I have to get off in next 10 seconds to get on another call. I apologize. There's some emergency that I have to leave.
Okay.
Is that okay? Is that okay, Dr. Mohanty?
No, yeah, that's fine. That's fine. Thanks a lot, Jay.
Thanks so much, Jay, for joining. Yeah,
answering all the questions, and I extend my heartfelt gratitude to you for being here with us and giving your excellent lecture and answering all the questions. Thank you very much.
Thank you. Great seeing you all, my friends. We'll see you very soon.
Thanks, Jay. Thanks so much.
Thank you. Bye-bye.
Bye. Now, Thorsten, can you tell us, yeah, I know that there should be dedicated centers where there will be infectious disease specialists as well as a microbiologist. You should have a good lab for culture as well, for extended culture, for fungal culture, anaerobes, everything, you know. That's why I agree with you. There should be dedicated centers for treating infection, otherwise it gets neglected. Now, my next question is that could you guide us in view of the recent pandemic, that what is your protocol for treating the patients for joint replacement? What precautions from the beginning how do you treat this patient for the benefit of our, delegates?
In which for which situation? I didn't catch it.
In COVID situation now, what
In
is your
COVID,
protocol
in
for doing a joint replacement surgery?
Yeah. So what we are doing is every patient. So first our protocol is first we call the patient 1 or 2 days by phone. I can show you. Can I show you a short video?
Yes, please.
Is it possible?
Yeah, you can split your screen now.
Let me see. And then because I have a video about it. So probably I show you one paper first. Can you see my screen?
Not yet.
Not yet. Wait 1 second. 1 second. No.
Yeah.
No.
Yeah, that's good.
This is presentation that I prepared for some other webinars. So I cannot find my mouse anymore. There. So as I show you a little bit about the situation, as you can see, in 2019 was like this, and every big places all over the world were crowded. The life was normal, and then Corona came, and I cannot really.
Lower left-hand corner, your arrows.
I cannot find my mouse, to be honest. I don't know why. Let me see. So no, it's not working.
In the lower left-hand corner, yeah, it's working.
Okay, but there's a movie. So we did this consensus meeting, and the new challenge, of course, that's why your question is absolutely okay. We did the new challenge is new Corona, which spread all over the world from China, as we know. Yesterday or today, May 29, we have about 360,000 confirmed deaths. So, and week by week, there's a big change of confirmed deaths. For example, here it seems that India is okay. It's about minus 10% every new week. Russia is on a very high, and as I told you before, this was the situation in 2019. That's the situation now, where we have empty places all over the world. And I would like to show you this video, but I cannot really find my mouse. I wanted to show you a video. No, but I show you our algorithm.
Or if you have the video separately, you can run it.
Yeah, I don't know why it doesn't work here in this. So, and this is the paper I like. So we did, Jay and Bill Walters from Sydney and I here in Hamburg, we did an ICM about resuming elective surgery in the COVID-19 area. So Jay told you already that the ICM consensus for periprosthetic joint infection lasted 2 years. And this paper we did in 1 week, to be honest. So we defined and described the consensus questions. We put up our work groups in Philadelphia, in Sydney, and here in Hamburg. We came to a conclusion. We came to recommendations. We sent the recommendations to 19 experts all over the world and to judge about it. And then they sent it back after 36 hours. We just gave them 36 hours to evaluate them. And then we submitted it to the GVGS, and after 8 days, it was published. Here you see the paper, and I like to encourage everybody of you, also everybody on YouTube, to read this paper, because all the unanswered questions are in there according to the available literature. The whole document is published in Ortho Evidence, very good paper. And this is a typical example of the questions. The questions one was, for example, when will the SARS-CoV-2 pandemic end? And our recommendation, of course, is nobody knows. It will end if we reach herd immunity, if we develop an effective vaccine, if the pathogen mutates, or we get an effective treatment. Another one, it's more about pre-admission. What additional steps should be taken during the pre-admission process? So we have to use, of course, soap, masks, social distancing, and so on and so on. These are all. Another very important question is, what kind of helmets, or should a surgeon use helmets? Should standard surgical helmets and protection suits be utilized when performing elective surgery during SARS-CoV-2 pandemic? And the answer was no. No helmets, please, because the fans of the helmet could be full of viruses, and the filters are not small enough for this virus. Another very important question, for me the most important one, is today we know that the most important way of transmission of COVID-19 is droplets, and especially aerosols. And they came out, it's really, I cannot understand. Here it is.
Now you got your mouse.
Yeah, I got my mouse. Yes, that's perfect. So there's a paper on the left side, visualizing speech-generated oral fluid droplets. And if you see this video here, it should, yeah. Droplets visualized by laser light without a mask. No, we're not working. That's shit. It's not working. I'll show it later to you. Okay. And there you could see in this video very well how good the protection of a mask is. So, and now I come to the end. It's really difficult here.
Is there a separate file for the video? Then you can just play it.
Yeah. Let me see if I can use it in that way. Yeah.
Now I'm recording.
So he's recording.
Stay healthy.
Without a mask.
Great. Stay.
Ah.
Now I'm recording. Stay healthy. Great. Stay healthy. Great. Less loud. Stay healthy.
Even if he speaks less loud, many droplets. And with a mask, a normal mask, not an FFP 2 or 3.
Stay healthy.
Nothing.
Louder. Stay healthy.
Nothing.
Louder. Stay healthy.
Nothing.
Nothing.
You see how protective a normal mask is. And so I like to show you a little in this video how we went back to elective surgery. Of course, everybody has to wear masks, everybody has to respect social distancing. And then we went back. So every country wanted to open the country.
Okay, and in the endoclinic, the lights went on again 4 weeks ago. So what we are doing, we call our patients 2 days before admission and go together by phone with him through a questionnaire where we're asking after symptoms, where we're asking after hospital stay during the last 2 weeks and so on. And if the secretary is filling every answer out with a no, the patient is allowed to come to the hospital. So, and the entrance in our hospital is very restricted. So you have to ring a bell to go in. Here's our patient again. He is going in. And he is guided in the hospital by marks on the floor to avoid face-to-face encounter. It's a one-way system that we established in our hospital. First step is he goes to the test. Every patient who is undergoing into surgery is tested. That means the patient is coming 1 day before, is tested, 4 to 6 hours later, we get the results. And then the patient is going to the anesthetist. And again, the anesthetist is going with him through the questionnaire. And if everything is okay, the patient is allowed to go on the ward. Follow the lines. In here, as I think it's the same in India, we limited the number of persons in our elevators, and then the treatment can start and the normality is coming back a little bit, and the door is open to our normal business, and our OR is very busy again. And so I mentioned it already, we are doing almost 100% of our cases. Visitors are extremely limited. Usually no visitors are allowed because they are not tested. Every visitor in special situation must get in permission by the director, that means by me. Here's the algorithm. Again, pre-sent information on intra-hospital corona protection, pre-inpatient telephone screening. If screening is negative, admission is possible. Then here are all the precautions that we have in our hospital. We have a green zone, a yellow zone, a red zone. Usually everybody who is in the green zone is going for the operation. I mentioned it, fortunately, during the last 800 cases, we had no COVID-19 positive patient. It's a very, very fragile structure. If we have one patient with COVID-19 who transmits it to other patients, then we can close the hospital again. Everybody in this hospital is aware about it. So we are extremely careful when we treat our patients. But I guess in this situation, with these precautions, you are quite safe. Yeah, thank you.
What do you do to your laminar airflow? Do you operate in laminar airflow theater?
Yeah.
Or?
We operate in laminar airflow fields without any changings. So we operate like in normal times because we had the questionnaire, the patient is tested, the patient is safe. So we have no special PPEs, nothing. So we operate like in normal times if the patient passed already all these steps.
And before discharge, again, the patient is tested for COVID or?
Before the discharge? No, that's not needed because the patient is just here. The patient has to wear a mask. Every staff member wears a mask. I'm not wearing a mask at the moment because I'm sitting alone in my office, but usually everybody has to wear a mask, even the patients, every visitor. So until now, we had no positive case. If we take a patient from another institution, we only take him
if he is negative. We ask the other institution to perform a test, and when the test is negative, we take him. If we have an emergency case like a sepsis or a severe fracture, we take him in our red zone here in the hospital, where he is completely isolated from every other patient until he is negative tested again.
Okay. Okay. Yeah, Asit, the last question, then we can move on to our cases. Please unmute yourself.
Thorsten, you said you don't use the helmet. So how do you perform this? You know, you're just wearing mask, or what protection, what you have?
Normal mask, what I'm normally using, a normal surgical mask and gloves. Eye protecting glasses was one with who are completely protecting my whole face. That's all.
Okay.
Some of my patients use shields, but no helmets.
Okay. So thank you, Thorsten, for that extensive, exposition of about infection in joint replacement, single stage, double stage,
Thank you.
at last to end with COVID-19. Now we'll move on to our cases.
Can I say, because I'm very sorry, I have also some other commitments.
No problem.
I have to leave, unfortunately. I'm very sorry, because they knocked all on my door here already.
No problem. On behalf of Indian Arthroplasty Association, it's a pleasure and honor to have you with us. And thank you very much for devoting the time in spite of your busy schedule. Thank you.
Hope to see you again soon in India.
Thanks very much, Thorsten.
Thank you.
Thank you. Pleasure.
Thank you.
Thanks.
Bye-bye. Bye-bye to all of you.
Thank you.
Bye.
Bye. Thank you.
So we start our presentations. May I request BJ to share your screen and go ahead with the first presentation.
Right. So great talks by Thorsten and Jay. So go on to our discussion. So this is okay. So this is my patient. At the age of 25, he had he's actually a case of angst-spawn. So he had bilateral ASR performed. Actually, this was performed in Delhi, and in so that was in 2007. So he was 26 years of age then. Then he was doing okay for 6 years, and following which he had pain in his right hip, and he had a very elevated cobalt chromium ions. So he underwent a revision of the right hip, the cemented, all cement revision, cemented socket and a cemented stem. And then he presented to us with this picture that was, sorry, I just go back to the previous one. Yeah. So he had this revision. This was done in 2016, sorry, 14. So that was done in 2014. And with this revision was done. So both cemented excited stem, cemented cup. And 2 years later, he presented to us with this X-ray of a failing cup on this side. Yeah. So the question is what to do. I think we're out of time, so I'll just proceed.
Yeah, please.
So we have to do a culture, has been emphasized by Thorsten and Jay. So we did a culture. We usually do it under CIAM. Sometimes we do it under ultrasound guidance. And his lab parameters were ESR 24, CRP 8, total count, and neutrophils were 58. So the MR didn't show any alter. So I mean, ideally, based on, I think, Jay's presentation today, probably in Philly, they would have done another tap after some time. But, we have our own compulsions. Patient has come elsewhere. It's a private practice. I mean, you can't be too theoretical. So with all these parameters, we decided to proceed with one stage aseptic revision. Anybody would think differently in India?
No, I think when the ESR CRP is okay and you have a dry tap, you should go ahead with one stage revision.
Yeah, so we went ahead with that. So that was the Perop findings. So we did a cement in cement revision, as you can see here. That's because we need access to the socket. So there was a huge bone loss from 12 o'clock to 4 o'clock portion after we removed the cup. I did a very good cementation, so we were able to do a good, and there was no pus, or there was no alter, there was no metal reaction, so everything looked very this thing. And I think one thing that we lack when you compare to endoclinic and Philly is that Perop diagnosis is what I think we really lack in our country. I mean, you can talk about leukocyte esterase and frozen section and doing a synovial count and things, Perop, but decision making based on that is very tough, I think. I'm sure you'd all agree with that. So we tried bits and pieces of, we're very good, we're as good as those guys pre-op, and our post-op regimens are getting to be equally good. But I think our Perop diagnosis is where we really lack today. So this was the thing. So we put a 58 Gription cup, and we put a 15 to 10 TM augment. You can see the steps of that. And that was the post-op reconstruction picture. We've done a cement and cement revision on the femoral side. Now the perioperative culture was positive, and this was sort of a very rare organism, Burkholderia spatiae. So that was what we grew on the Perop cultures. So we have protocol of sending Perop cultures. So we followed up with the routine ESR-CRP assessment, and he was on 2 weeks of IV antibiotics as per the international now consensus. He was on 4 weeks of oral antibiotic, and then he had a 2-week antibiotic off period, and then his parameters were like this. So they were good. And even after the antibiotic off period, 8th week, his parameters were normal. So we, we just like the international consensus now, we thought that everything is fine. Now, just a word about this organism. It's an aerobic gram-negative bacillus. It's found in aquatic environments, and this is an organism of very low virulence. And it's a frequent colonizer of fluids used in hospital, irrigation solution. It's supposed to be a colonizing thing of that. Of course, this was not from our hospital, the index surgery. So he was doing well, and 1 year post-op, he was happy with the result. But at 16 months, he came to us with his failing implant. Then at that time, his ESR was 70 and CRP was 36. So now, within 1.5 years, it has failed. And now, because he had a PGI, we knew that, what we missed was the PGI. Now, if we had done something like a revision on the femoral side as well, we probably could have called it a one-stage revision. But this is since we retained all the cement, we didn't do a good debridement. So that would be we would think that is the cause of failure. Anybody has got any other thoughts on this?
I think you have to go ahead with 2 stage now. You have to take out everything, put cement spacer, treat with antibiotics.
I think there is no other choice here.
Vijay,
yes, please.
When you did the first revision, what was the culture? Was the culture negative at the time of first revision?
No, he told no.
TSR to THR.
We have
already told that.
We have no records of that.
No, he
has not been. We don't have records of that. Done elsewhere, we don't have records of that. Yeah.
Because that is the time probably the infection must have been could have been picked up, isn't it?
Yeah, that's correct. But as Thorsten was saying, we don't have dedicated centers. You don't even have joint replacement centers. Somebody who does trauma does a revision for infection, things like that, and that's why we sort of miss out these things, I think. So we plan for a 2-stage revision, and this is our way of doing it. We never put an articular spacer. We put an individual dowel in the femur, an individual ball in the. We never have any problems with the overriding femur, etc. We never have any problems. We have no complications with this kind of spacers. It works very well in our hands. So again, the same organism grew, Burkholderia spacea on the second thing as well. And then he again went on to antibiotic. And I don't have the results of that, but he was fine because he was selling it from Delhi, and I don't have really. But once his thing became normal, we took him for second stage surgery. So again, we had bone loss. This time we decided to use a TM shell. So we had to put a large TM shell. That was the thing. And this time, of course, the most important thing is we have revised the femur as well. That's the difference between the first revision and this second. And if I have noticed, the interim is other ASR became painful, and I had to do a THR on that side as well. So this is 3-year follow-up, and he is very pleased with the result. So this case is being presented that every unexplained early failure, and when you can't explain failure, it's probably a low virulent organism. And I think we must all keep that in mind. Although it is low virulence, it's difficult to grow it. That all adds up. So when you can't explain the failure, aseptic failure, then it is infection. That I think is the moral of this story.
Yeah.
So,
yeah, there are 2-3 important messages from this. That first one, that what Vijay told, that early failure leads to infection. Within 2 years, if your hip is failing, then 50% chances that it will be infection. Number 2, even if the ESR and CRP is normal, that you cannot exclude infection because of these low virulent organisms like Burkholderia. Also in some other organisms that are low growing organism, the ESR CRP will be normal. So you go ahead with the single stage revision, but during every revision, one should remember that to take the cultures of the tissue samples, membranes from around the femoral side, from the acetabular side, the joint fluid, minimum 5 to 6 samples should be taken. And post-operatively, number 3, if it has come out to be infection, that is a type 1 infection. That means, you have done a infection is supposedly for aseptic revision. So in those cases, the antibiotic has to be continued for about, say, 6 to 8 weeks, as Vijay did. Any questions on this?
Vijay, my question to you is, what is your experience? The most of the culture positive you find from the implant wash, or you find from the other these tissue samples?
So tissue samples we have. So
in my experience, the implant wash has been the most important.
I'm not sure about that. The consensus statement says, you have minimum 5 samples, deep samples. You have to take tissue, and inoculating into the blood culture bottles when you have an fluid there. All those consensus statement guidelines we follow. Our yield rate is quite high, I must say. Yield rate is quite high when we follow these protocols. Subhranshu, let me ask you, what would you have done differently in this case?
No, I would have done the same way, that since ESR CRP is normal, aspiration was negative. So I would have gone ahead with the single stage revision. But intraoperatively, many times I send frozen section. I tell the patho people beforehand, and I take from the most inflamed site, I take the tissues and send it. And if I find that there are more than 10 polymorphonuclear cells per hyperfield, then I would have put a spacer and come out during that time. But if it is 5 to 10 or less than 5, it is doubtful. I would have gone out with a single stage revision like you did and sent the samples, 5-6 samples for culture post-operatively.
Vijay, can I ask you something?
Yes.
See, this particular organism that is there is very rare. So do you speak to your microbiologist, or for that case, even Mohanty, who does a lot of infection work, do you speak to your microbiologist that to culture them differently, or this is through routine culture that you got this organism?
No, we talk to the microbiologists all the time, and immediately they will call us and tell us, that this is what they are finding provisionally, and you got to be in constant touch with the microbiologist. That's one of the secrets of how we can do well. We have a WhatsApp group, and we are in constant the ID guy as well, and so it's like everybody's on the game. That's why that's how you'll pick up all this. Yeah.
Yes.
Just to add to that, sir. So do you go for an extended spectrum for all your specimens?
Yes. Absolutely.
Okay.
Culture we have. But looking back, after the experience that we had with this case and a few similar cases, now what I would do is 2020, we got the same patient. I would do a full 1-stage revision. I would treat as infection. I would have taken the cement out, and I would do only 1 stage, but I do it one stage. I wouldn't have left the cement in, the biofilm and all that. Now I would have done that. I would
Yes, sir.
treat this is a classical case for our people to do one stage.
Yes, sir.
Do it at the one stage, and your chance of success would be very high, I think. Yeah.
No,
Yes,
you have to send the samples immediately to the laboratory for culture. You don't keep the sample there. That is the biggest mistake what we see in our scenario. Number two, microbiologist has to do extended culture from 14 to 21 days. In some of our institutes, like Just Look Hospital and all, they in every sample they do this extended culture, but they don't inform you if it doesn't become positive. So you go ahead with the treatment and all these things, and if it becomes positive, they will call you and they will inform that it has become positive after 14 days or 21 days. Yes, last question, Asit, and before we move on to the next question.
Vijay, again, for a single stage revision, as Thorsten just told us, we should have the organism, we should have that organism, that this is the organism and this is the antibiotic that is susceptible to it. In your case, you mentioned that you would have gone with the first stage if this case was presenting to you today.
No, the situation is, we don't know it's infected. Yeah, it's query infected, and we don't know the bug is not there because we think it's not infected. Yeah, so it's a little different. We are not dealing with PGI. They're only query infected case. We only have not explained the failure. So putting all things together, it's better to go and do it as in one stage. This is your classical case. They gain experience to do on one stage. Yeah, so your chance will be high. This is not PGI. Quite different. Yeah.
Yeah. Before we go to Kalai's case, how many of us do one stage revision? Any of the faculty?
Yeah, we have done isolated cases.
Only in limited number of cases where the bacteria before time and the host strength, the patient is healthy, no comorbid conditions like the uncontrolled diabetes or rheumatoid.
Yeah.
Only these cases.
Okay. So, Dr. Kalai Banan, can you go ahead with your presentation, please?
Yes, sir. Thank you, sir. Am I audible?
Yes, please.
Yes, sir. So we broadly classify the two treatments. One is invasive and non-invasive. Here we are sharing one case. He is like 42-year-old male, known ankylosing spondylitis, HLA-B27 positive. He was on sulfasalazine tablet. He got his left hip replaced in 2017. And after 2 years, he came to us to get his right side done. He is a known alcoholic and the BMI is on a bit upper side on 32. So it was like just a straightforward case. So the surgery went fine. Initial 4 days was uneventful. He was about to get discharged. And it was a Sunday, so he wanted to go on Monday because of the insurance. So Sunday night, he had a party with his friends. He had some outside food. Monday morning, he developed diarrhea and a fever of around like 100. So we put him on prophylactic IV antibiotics. Generally, we gave Sufasif, and this time we gave injection Magnus-4. And abdominal, on day 6, he had abdominal pain, but he was moving around. 7, abdominal discomfort, but no hip pain. And 8th day, he started having pain in the knee joint and swelling, and a bit of feverish, rigors and chills. So we thought it might be some reactive. And 9, it was a bit more severe. So we were thinking of, since obese, we thought of it might be a DVT. So we did a venous Doppler. There was no DVT. Then we wanted to find a foci, anything above the diaphragm or below the diaphragm. So we did a CT screening, but nothing, no pulmonary embolism and no other collection. But it showed some subcutaneous collection over the distal thigh and in the suprapatellar region. And we have the habit of doing ESR CRP whenever the patient has some implants. So his ESR CRP was within normal limits. And so that's the reason we proceeded for the second side of hip replacement. So because it was a fever and chills, generally our ID team thinks of like dengue, malaria, because we get a lot of patients coming from outside. So dengue, malaria, that everything was negative. But the CRP was way rocket high of 400 plus. D-dimer, we nowadays started doing a D-dimer and interleukin 6. That was also like high. Procalcitonin, yeah, it was also high. So we did a bedside ultrasound guided knee aspiration, and we made sure that it goes into a direct inoculation with the pediatric Bacterial bottle. And the 24-hour signal grew something like Echinella cordon, which is a gram-negative, and Streptococcus constellitis, which is a gram-positive. And even the 5th day growth also confirmed those two things, which was like unusual. So, and the next day, within the 24 hours of aspiration, we didn't have any much time. The infection was much more severe. his whole of the thigh become red, and liters of pus started pouring from the surgical site. So we just took him to the OT without any delay. And we do a radical debridement, almost a oncological basis type of. We start from the layers, skin, we clean it up, scar, and the subcutaneous, then open the fascia, and then go into the joint. And we do with a very aggressive manner 2 times and everything. And surprisingly, here the muscles and fascia was like in other infections like Klebsiella and gram-negative, some you will feel a scar tissue or tethering of the tissue. Here nothing was there. All the muscle fibers, everything was like perfect. We can see a sheet of pus flowing through all the from the joint to in the subcutaneous level, just like a leveling or a lesion it was looking. And we also then we also do the rule of 3 minutes of betadine. We soak it, wash it with again high pulse jet lavage, and again we soak it with 3 minutes of hydrogen peroxide, and again wash it out, and again we used to soak it with 3 minutes of vancomycin. We strongly believe that almost all the infections are polymicrobial. So we, since we target more of gram-positive in IV, we used to give vancomycin soakage for 3 minutes, then again wash it with. And we, like it was a tough case, ankylosing spondylitis, we just changed the ceramic ball alone. And we were not sure, because when we saw the liters of pus, whether we have to revise the implant, or it's just, and we don't want to do a half-hearted job. Since we are taken for a wash, we give the full effort to save the joint. And we made sure that 5 samples have been sent for the culture method. And whenever we do a diet on a basis, we used to add extra amount of antibiotic in the form of intraosseous antibiotic or some stimulants or even a catheter. But this case was a bit particular, and it was within 2 weeks, such a huge pouring pus, we don't want to add something like stimulants. And for all of our primary cases, we don't keep drain. But this was a bit unusual. Here, we know it was like not a routine infection, and it was like we can see the sheet of flowing all over the thigh. So we had 2 drains, deep drains and 2 superficial drains. And the deep drains generally we keep in almost all our revision cases for a period of 2 to 3 days. But here we kept it for a period of 9 days, because the amount of collection from the joint deep was coming down. But the superficial remained around like 100 plus, and we had to remove it like 18th day, because we don't want to take chance, because it might form a sinus. And followed by we used a Smith and Nephew Pico dressing twice, 2 sittings for 6 days, and this was the final result. The wound got completely healed up and everything was fine. So at the end of the day, we had a meeting with the ID team. So we had 2 organisms, and from the synovial fluid aspiration, and from the tissues, 3 tissues and 2 pus culture. We made sure that the 3 tissue samples, 1 goes for manual method, routine agar plate method, and 1 goes for the automated, where we have the MALDI-TOF, which throws signals in 24 hours, and the final comes in the 5th day. And micropack 2, it includes gram stain, AFB stain, aerobic, anaerobic, fungal, and also MGIT, and they keep it for 45 days to rule out TB. In this case, we had a doubt of TB, so we sent a gene expert also, that was also negative. And the pus manual method initially grew gram positive, but the 5th day didn't grow anything. Automated grew both preliminary and a final came as methicillin resistant Staphylococcus epidermidis. So we went through the literature, and we have a WhatsApp group in touch with the infectious disease specialists, microbiologists, and pathologists. And we also gone through the literature, like which will be like suiting the Streptococcus. And all these organisms are not new, and some case reports are there in relation with the PGI. So this is the HRI follow-up sheet. So here we routinely follow up with the antibiotics and the ESR, CRP, and the hemoglobin level. If you watch carefully from like October and to like 22, there was a constant drop in hemoglobin, which was, and here CRP was rocket high. Initially, he was on Sufosef, and when he had a diarrhea, we gave an injection Magnasfort and Targocid. When the synovial fluid aspiration result came, we started him on its sensitive tigecycline, augmentin. And again, but the total count went into 40,000. So we had to add augmentin. It was like a much more antibiotic dose, which we didn't use to, which was like we don't give repeatedly. And we had 3 blood transfusions. And after this final discussion, we found tigecycline was effective. 100 was given as a stat and 50 BD thrice. And once the ESR CRP was like within the range, 3 consecutive readings of more than 3 weeks, Then we shifted him to oral antibiotics. And whenever we have implant, we consider rifampicin. That also works good for MRSA and as well as the streptococcus. And levofloxacin works, and minocycline especially for the echinella. And for 2 weeks, we gave 3 antibiotics and made sure that the CRP was within normal limit. Then we shifted him on 2 antibiotic dosage under rifampicin and the revofloxacin. And whenever we give antibiotic for more than a period of 2 months, we have the habit of giving fluconazole 1 dose, just like a prophylactic measure, and also like augments. And we made sure that the CRP still remained within the normal limit. Generally, we aim for less than 10 and ESR less than 40, but here it was surprisingly much more less, and the antibiotics was stopped. This was the latest rating which shows like improvement in the hemoglobin and the ESR CRP is like that. So this case was like much more particular because the liters pouring from within the second week. And we almost like initially we thought we have to revise all the implants. We are planning for a 2-stage seeing the pus, but we did a DAR and we gave antibiotics quite a long time. Anyway, it's been like almost like 7 months follow-up. It is very short to say anything, but DAR works better when you do your debridement and culture. When you talk with the ID people, microbiologist and histopathologist, and come to a conclusion. Thank you, sir.
Yeah. Thank you, Kalai. That was a very good case. So can you just tell us what are the indications of DAR for the benefit of our delegates? Yeah.
So like say,
can you stop sharing your screen? Yeah.
Yes, sir.
Yeah.
So whenever like the infection we see, as Thorsten sir described, when it is like less than 3 weeks, when the biofilm is not formed, we are like 100% sure that the DAR is going to work. And in conditions like we have a PGRI score in which like we give importance to all the comorbidities and all the facts. So depending upon the AGI score, we decide like which is going to work much more better. And like for another case, a old lady, she came with this, like she was not having diabetes, hypertension or nothing. She was almost like 5 years follow-up, TKR, everything was fine. But we have already used a stem because of osteoporotic bone. But when she presented with it, it was almost with a pus. But our scoring system, she had a very less score. She was in the green zone. And so this was a case, ideally, we took it for a DAR procedure. We didn't take the implants was also confirmed that it was intraoperatively stable. We gave a thorough washout and aggressive. We added stimulants and antibiotic and everything. And she was under chronic antibiotic suppression therapy for a while, almost for like 7 months. We had a regular follow-up with the ESR, CRP and everything. And this works. So we have to choose the cases which is meant for DAR. So we believe that we give a scoring system based on their comorbidities, age, sex, and all these things. And if it is the green zone, it works. Sometimes the patient comes where they are like were not like medically fit. We had like a couple of patients because more than the people living more than 8 years, it's getting more and more. And those are getting replacement is also more and more. We have a couple of patients who can't withstand a surgical procedure of more than say 1.5 hours, like 1-stage revision or a 2-stage revision or a bone loss they can't afford. That time, DAR works as a principle where you reduce the bacterial load so that the amount of antibiotic going to be given is also comes short. So this is going to helpful. So it depends upon like how you choose the patient. So early cases, yes, it works. And chronic cases with a less AGRI PGI score, yes, it works. And it can be one of the salvage procedure or a helpful procedure in patients, old patients, even though there is like ESR, CRP like high and they can't afford for a 1-stage or 2-stage.
Yeah, you know, debridement, antibiotics and implant rotation,
Yes,
it
sir.
works if you're in acute infections less than 3 weeks of duration or the joint age is less than 3 weeks.
Yes, sir.
They're the 2 indications. But there are certain, poor prognostic indicators. If the ESR is more than 60, the CRP is more than 60, or if the rheumatoids, inflammatory arthritis, if there is a presence of a sinus or
Yes,
the implant is loose, these are the conditions where one should not perform a DAR. Now any of the faculties, how many DARs should you do? The question is that suppose first DAR it fails, you do go for a second DAR or you go for a 2-stage revision? How many DARs should you do?
One.
If we have done the DARE, it's one. But if like anything else, you get specialized at it. Yeah. So done outside, we would repeat the DARE. That certainly, if they come acutely, we are quite happy to repeat the DARE.
And that's what I meant. If you've done one and then straight away two-stage revision, if the first DARE which you have done has failed.
Yeah. So only one DARE is indicated. After that, then you should go ahead with the sources revision. Yes, Krishna.
The literature says two. You can look at 2 days you have done or anybody. If you do more than 2 days, there is high failure. That's the literature. And previous question on one stage selection criteria, the paper which Dr. Thorsten showed on the Argenson's group from France, they looked at pre-selected criteria versus no selection criteria for one stage revision, and they found no difference. So there was one group of surgeons who was doing one stage revision irrespective of the organism. They don't know the organism, the comorbid condition, and they looked at the other centers which were doing revision, and it's a large series of almost 1100 patients, and they found that it's very unclear at this point in time or impractical to say, okay, this is a criteria for one stage. To identify the organism, it's almost impossible to identify the organism in all the situations. So their rate of culture negative was almost 35%. So what they found in their study was whether you had criteria for doing single stage or no criteria, the outcome was not much different.
Okay. So one more important thing about DARE, that DARE should not be done as an emergency procedure. If you have diagnosed the patient, infection, if you have decided DARE, you do in the next day in the routine theater, rather than doing it in the emergency theater, as you do in a fracture surgery or anything. That is one of the recommendations. So let's go ahead with the next presentation by Dr. Sanjeev Jain. Yeah. Can you unmute yourself?
Okay. Am I audible now?
Yeah.
All right, fine. Sorry. So it's a very short case. The patient who's a 49 years old gentleman who had an acetabular fracture, implant was done and it's got infected. And so this is a pre-op x-rays. He was operated elsewhere. And within 3 months' time, he had an infection. He came back to me. They have done the debridement twice, I suppose, in another institution. And he came back to me with a discharging sinus with naturally high CBC, CRP, and ESR. So, this was done in that institute from where he had come with an unstable spacer because of the posterior fragment at the time of removal of the implant. Probably that posterior fragment was also removed completely, which was or absorbed, whatever it may be. And he came to me with this situation. He was painful as well because he couldn't walk. Since there was a discharging sinus, CRP and ESR was raised, we have thoroughly taken it out and debrided the whole thing, and we left him as an excision orthoplasty because anything which you could put it here, possibly because of the defect, we could not have a successful spacer inside. So I left him like this and put him on the sensitive. It was staph sensitive antibiotics, as suggested by all other faculties earlier, and within 3 to 4 months, his CRP, SR came down. He never had any issue. And we did the CT scan preoperatively when we went inside, and there was a defect in the definitely posterior superior wall, which was not there. And then we had to reconstruct it. This was an intra-op picture. There was practically, it was very clean at the time of operation. This was an acetabulum, which was, and we had to put, like Vijay showed, the augments there to posterior superior wall. We reconstructed it, and this is an intra-op picture. We had put an uncemented socket and uncemented stem with ceramic and poly, And this was the final reconstruct. It's around 6 to 8 weeks now for him to have this surgery done. And this was the post-op for the socket and the stem stable. Of course, he's on non-weight bearing walking at present time, and I'm awaiting the further progress and see next 6 months to 1 year time what happens. So this was the whole thing about this patient, where the implant failure, infection, unstable spacer. We reconstructed the posterior wall after everything was fine, and we had put him onto 6 weeks of oral antibiotic discharge.
Thank you. So one important message from this case is that when there's an unstable spacer, infection doesn't get controlled. So now question is that what are the criteria of putting a proper spacer inside a hip? Anyone like to take that? Can you stop sharing your screen, please?
Yeah.
Yeah. What are the criteria for putting a proper spacer inside a hip? Yeah. So the first thing is that spacer has to be stable. And number two, most of the times, we give the neck shaft angle is more, like, 125, 135 degree. When there is a valgus, angle, the spacer usually is unstable. So ideally, when you put a spacer, one has to give little varus, or, your neck shaft angle should be maybe around, say, 100 degrees or something like that, because it's a temporary spacer. And I'll just, share the screen, just show you one thing.
But Dr. Mohanty, this was basically a posterior wall fragment, but the posterior wall was not there practically. Yeah. That's why this spacer was unstable. So I would like to have a question to, especially to the Vijay, in such situation, when there's no posterior wall, what do you do as far as the spacer is concerned?
Well, as I said in the thing, all our spacers, no matter situation, we put non-articulated spacers.
Yes.
We'll put a ball in the socket. That definitely stays there, and then we'll put a separate dowel in the femur. Now, I got to qualify what Mohanty said. When you say, that you cannot, infection will not subside when there is instability, it is not to the joint. It is in a long bone, what you're talking about. In a joint, there is no question of instability. Joint is meant to move. So that doesn't apply directly here. So when you use a non-articulated spacer, infection will subside. So we cannot mix a long bone and a joint. That's completely different context.
You can put in that case what Vijay told, that you can put two separate spacers on the femoral side as well on the acetabular side, or else you can put multiple antibiotic beads inside the cerebellum as well as on the femoral side. Yeah, Rajiv.
Yeah, but Subranshu, this instability does not work with spacer. That's a different concept. Not confuse that. Yeah.
The purposes for putting the spacer are two. One, that it is filling up the dead space, and second is that it is keeping the tension of the soft tissues till the time you are coming back for the revision. So Vijay, your method is very good, that you have the two separate things, but what is the harm if you are able to put a spacer which is like a normal implant, because that will also maintain the tissue tension, and it will make the final surgery much more easier for you.
I will tell you, it doesn't make your final surgery easier, because we are so used to operating on dysplastic hips, high riding hips. So a little bit of shortening for any one of us releasing is not a problem.
Right.
Number two is when you put an articulated spacer and it dislocates like this case, or it does a fracture. But more important than all that, I find there's eventually bone loss, because it's loose. It tends to either have acetabular bone loss or femoral bone loss if you don't simulate properly. If you simulate properly, then removing that cement at the time of surgery takes 40 minutes, 1 hour. And that's the precious time that you have for revision surgery. Yeah. So we don't like to waste time during a revision surgery. We just take it off in 1 second and we get on with the revision surgery.
Yeah, I agree with Vijay. Hip situation, it's a difficult than knee. So it's always instability is a big problem. So if you put two spacers, I think that is a viable option.
Yeah, I just share a video, 2 minutes video, that how we put our spacers. This is a new indigenous templates made of polyselection. This material is autoclavable and reusable. This is soft, malleable. You can adjust the offset, length, adjust the diameter because there are 5 different sizes available. This one is 41 diameter. You can adjust the version also, and it provides a rotational stability, and it easily can be removed during second stage. You can use one of these like K-nail or Eligera rod or Ross nail depending the canal diameter. As you can see here that you put it like that, you adjust the offset there. So this is like high offset. If you do like that, then it is low offset. So this is a small video just to see that how to prepare the spacer there, and these are reusable, autoclavable 100 times. You can use this. So these are dislocated, infected bipolar. This is the lateral view. So always excise the sinus tract there. So take out your extraction of the prosthesis, whatever way you can do. Then you thorough lavas with betadine, hydrogen peroxide. You use the pulse lavas. This is a K-nail which you are bending with the plate bender. So you bend it, and to desired degree angle you can give. Then these are the templates which are available. So you take the antibiotics first, thoroughly mix the powder with the cement powder. Then we add the liquid. So after it is prepared, then you put it inside the template like that, the cement. Then you put the bent K-nail inside it and put all the cement inside, give the desired degree of offset there. Then you hold it till it sets. So when this is being prepared, the whatever cement is left with you, you can prepare the cement bits with taking the stainless steel wire. And now the cement is just about to set. At this point of time, you can take your nibbler or any bone cutter, just trim whatever excessive cement is there, and now your spacer is ready there. Now put it inside the canal, and it just snugly fits inside this canal. And as you can see here, if it doesn't fit snugly, if the canal is wide, you can put a little bit of cement, one other packet of cement, and set it like that. So you put these bits in the soft tissues. That is the post-operative X-ray of this patient, and patient can walk immediately there. So at this point, if the bone is osteoporotic or it doesn't snugly fit, then you can put another packet of cement there just to cement the spacer into the proximal part of the femur there. So that is immediate post-operative mobilization. This is one of the patient where it's excised hip. Vijay knows about this case, who was 12 times operated, infection not controlled, and multiple incisions, multiple discharging sinuses. Patient is not able to walk because of the unstable situation there. So we put our spacer, that is in August 2015, and the infection got controlled. It is just about 6 weeks, but the spacer broke because a patient walked over it, heavyweight patient, because of more neck shaft angle probably. But though the infection got controlled at 6 weeks, I didn't want to go ahead with the second stage surgeries. So I did that was the 13th surgery. This is the 14th surgery. Here I took a cemented CDH kind of prosthesis, stacked it over a K-nail, and with our template, we prepared the spacer. Then it put the spacer in, and then the infection, of course, was controlled. In June 2016, converted to a second stage, and that is about 3.5 years follow-up of this patient. Working with little bit of abductor lurch on the left side because of repeated surgery, and that was the 15th surgery, and the infection is controlled in this patient.
Fantastic.
So, is there any question from the YouTube, Abhinav?
Yes, sir, we've got one question regarding something that has not been discussed till yet is what about fungal infections in the joints? Does everyone go for a routine fungal detection, or do you have a special indication when you should suspect a fungal infection in a joint?
Yes, anybody would like to take that question?
Yeah, we routinely send for fungal cultures, all our things. We get tuberculosis and fungal as routine cultures.
Yeah. When the ESR, CRP are normal, and if you see that a joint is infected, but ESR, CRP has become normal, these are the indications where there might be low grade infection like Burkholderia, what Dr. Vijay was showed. You should send it for fungal culture, as well as in our country, you should send it for tuberculosis. Okay. So these are the three things one must look for. So low grade organisms or fungal culture or tuberculosis. And if you find fungus, these are more difficult cases to treat. There you have to add amphotericin B and voriconazole. These are the two antifungal agents.
Long time.
Yeah, these are available in powder form, and you have to treat with antifungal agents for about at least 6 months, depending upon your infectious disease specialist advice. So let's go ahead with the next
Can I make
case?
one point about Sanjeev's case?
Yeah.
So Sanjeev, very good result. But I think there must be no indication where you don't put a spacer for antibiotic delivery. You must put some kind of local antibiotic, because that's the whole idea of a two-stage.
Yes,
So
yes, agree.
you must put
Completely agree.
some kind of antibiotic delivery, local, so critical for every patient.
Accepted.
Very important. Yeah.
Accepted.
Okay, we move on to a case by Dr. Bhosle. Let's move on to the knee. Yeah.
Yeah. Articulating spacer is very important. So I'll give you highlights of one interesting case. So this is a 64-year male, my old patient. 10 years ago, I had done bilateral two-stage revision for infection, both the knees with the revision processes. It was successful for 10 years. Right knee got recurrence of the infection now, about 7 years ago. There's a frank thick pus on aspiration. It was streptococcal, sensitive to many antibiotics. No infection on left side on aspiration. Diabetes, HbA1c was 9 on insulin, uncontrolled. Obese, BMI 38. So this was a case. Left knee was aseptic with periprosthetic fracture, gross osteolysis, which was very unusual. So this is the right side, 10 years post two-stage frank infection. ESR was 120, CRP was 200. And this was a aspiration microbiology report which shows streptococci sensitive to most of the antibiotics. 10 years ago old, he had Staph aureus. So this was a treatment. We did radical debridement, articulating spacer, introp, stable on range of movement. And it was hand molded, which gives customized quality and quantity of the antibiotics. And over a period of 6 weeks, ESR came to from 120 to 28, CRP 200 to 6. One very important, this was a handmade, it has to be very smooth so that there is no particulate debris during movement. And these are the 4 types of articular spaces available in the literature. Number 1 is cement on cement molded. Second is metal on poly. Third is cement on cement handmade. And fourth is cement on cement prefabricated. And these are 3 important factors: debridement, antibiotic selection, and stable spacer. So this is one very interesting article where they have reviewed 34 articles for articulating spacers, and from the literature, so out of 34, 12 were molded, 11 were metal on poly, 7 were handmade, and 4 articles on prefabricated cement on cement. So issues with articular spacers, stability is very important for articular spacers. Whenever you made a handmade, the surface is very important, because whenever you do movement, there's a debris coming from the bone, from the cement, and that can be dangerous. It can lead to fibrosis and additional tissue. Mechanical failure, if sometimes it is thin at some places, it can crack and can cause extra problem. If it is too loose, there's a big instability. And one issue with the metal on poly, it is very adhesive for bacterial adhesions. So radical debridement is a key part, and during same time you must plan for future revision, do all the whatever measurement and do good planning. And this is what we have done, next gen rotating hinge, which was good, healed very well. Other side, there was a gross osteolysis, aseptic. You can see there's a periprosthetic fracture, osteolysis, both tibia and femur. And we did intramedullary impaction bone graft, trabecular metal cone, femur and tibia, and rotating hinge knee, which was quite stable. And this was 7-year follow-up, both the RHK, and you can see the impaction bone grafting healed very well, and both the knee healed very well. There was no issue. 7 years post-op. So in conclusion, articular spacer improves mobility of the joint with reduction of arthrofibrosis and is more advanced technology than static, prevents quadriceps contracture, preserves bone and better antibiotic delivery because of the movement, better functional outcome post first and second stage surgery. Intra-op cement spacer can provide delivery of custom-made type of antibiotic and quantity of antibiotic. Infection from one knee usually does not cross across opposite knee, but you should always do infected site first and then go to non-infected for reconstruction. Radical debridement is a most important part. Stable, whatever you make a spacer, it should be stable on range of movement, and partial weight bearing should be permitted. Infected site should be done first. Recurrence can occur with different organism. Obesity and uncontrolled diabetes are high risk factors for reinfection. And in this case, aseptic osteolysis could be wear related issue. Thank you.
Thank you, Dr. Bosley. That was excellent. That there are 3 types of articulating spacer you can put. Either you can mold it on the table himself, as Dr. Bosley shown.
4 types, yeah.
Or you can prepare the available molds which are available in the market, or else you can re-autoclave the extracted prosthesis and put it back with a polyethylene on the tibial side. What we'll do, we'll take up Rajiv's case first, and then we'll discuss both the cases together, because Rajiv is showing a static spacer. Then we can have, there are a couple of questions from YouTube that when you put static, when you put, dynamic spacers. Yeah, Rajiv, please.
Thank you, Shubhranshu. I think it's a wonderful pace that has been set up by the 2 stalwarts of periprosthetic joint infection, Jawad, Parvizi, and Thorsten. An excellent case as shown by our colleagues. Now, Shubhranshu, I'll be showing the 2-stage revision for an infected knee using the static spacer.
Yeah.
Now, the static spacers are needed in various conditions, especially where you have the instability in the area. Eradication of the joint infection and providing a painless functioning joint is important. In my views, the host factors, virulence of the load of the bacteria, and the local wound factors are 3 most important issues that anyone who's dealing with the periprosthetic joint infection should look at it. This is the patient who's having the discharging sinus over the antler part of the knee. He has difficulty in walking, and most of these patients will have the limited range of this is the post-operative patient of this patient, and you can see that there is some instability, but it is not showing the amount of instability that the patient had, because this is just a weight-bearing X-ray and it is not in the valgus or varus stress. So this patient had not just the infection, but also a grossly unstable joint. That you see the varus stress and the valgus stress, and you see that there is so much of instability of the spacer. And also in the flexion, there was a lot of mismatch between the extension and the flexion gap. The implants were extracted using the fine osteotomes. Bone should be preserved as much as possible in all these cases. Minimal bone defect was seen on the lateral condyle, and the cement I try to remove it using the high-speed burr, and that makes it very easy to remove the cement from the small nooks and corners. And that's what you see, that after removing the cement, you see a clean joint. You see a significant inefficiency of the middle collateral ligament, significant inefficiency of the lateral collateral ligament, and there was a gross mismatch between the flexion and extension gaps. Now the choice of the cement spacers, what Pradeep had shown very well, the articulating spacers or the cement block. Articulating spacers could be the factory made, the company made. You can make it on the table as you see here, both for the femur as well as for the tibia, or you can use the autoclaved femur and then make the mold for the tibia, or you can use a cement block as you see here. In this patient, we use the cement block because there was an instability. In all these infected cases, I always use this medullary stem, which is made of the cement, and you can make it very easily by molding by your hand or using the cement gun, the front part of the cement gun. You can keep moving it, and then at the end of cement setting, you can just tap it off very easily, and you have a nice rod made of the cement only. You can add a small K-wire also into it, or a Steinman pin, or you can just use it just like that. And Peleco cement is preferred because one, it has a good color, which differentiates between the bone and the cement, and also it has a better antibiotic delivery capability. And you must make sure that the wound, after you put the cement spacer, the static one, the wound is able to close. It should not be too much of filled in cement that you're not able to close the wound. This is the important thing, and that's what you see the post-operative X-ray. You see the rods with the K-wires and the cement block. If you're not having the Peleco cement, you can just use the methylene blue in the normal cement. The culture of this patient was positive. We normally send 6 cultures from the medullary cavities, from the implant wash, and we try to stir the implant wash also, so that it is there for about 20 minutes. We take up the implant wash and all these cultures directly into the bacterial bottles. All the patients, as a routine, go for the normal culture and the fungal culture and tubercular culture. This patient had the MRSA. Sensitivity was to vancomycin, which was given for a period intravenous, was given for a period of 4 weeks. Linezolid was sensitive, 600 mg for 3 weeks intravenous, and another 6 weeks it was given oral. We always add rifampicin in most of our cases, because rifampicin has a better penetration to the bone, and of course we test the sensitivity to rifampicin as well in all cases. This patient in the revision second stage, you see that the antibiotic impregnated spacer is visible. The tibial tubercle osteotomy was done because to make the exposure easy. In our hand, tibial tubercle osteotomy is very simple. You make a 6 to 8 centimeter long and at least 1.5 centimeter thick tibial tubercle osteotomy. Remove all the cement. Remove the intramedullary spacers, which is very easy to remove. And again, the implant wash of the cement should be sent at the time of the second stage revision. Use the high-speed burr to clean the bone, which is a very good way to clean the bone. And you see that when you use a static spacer for a period of almost 3 months, you see that the flexion gap is reasonably balanced, extension gap is reasonably balanced, because the fibrous tissue formation takes place. Otherwise, you had to use the rotating hinge for such a patient. But if you use the static spacers, you may be able to to have the benefit of stability, which is because of the fibrous tissue, and you may be able to use a less constrained implant. You see the spacer in flexion, spacer is in extension, and that's what you see after the implantation, and the trial implants and final implant, and the final closed wound. That's what you see the X-ray of this patient at the follow-up of 2 years. Usually to fix the tibial tubercle osteotomy, you just need the 2 screws. And you see this patient who has almost a 90-degree function of the knee. You see this patient walking. The knee is stable at the follow-up of 2 years, and she has a reasonably good function. And that's the X-ray at 7 years. You see the function at 7 years. And you see this function at 7 years. So even if the patient is having the instability, the second stage revision, after achieving the fibrous tissues, the stability with the fibrous tissues. You use the surgery very carefully. Do not release too much. And in these patients, you are able to have a very stable joint using the minimal constraint, which is the TC3 implant here. Thank you, Shubhraj.
Yeah. Thank you, Rajiv. Very good learning points. The first thing is that when there is a instability in the knee, then you put a static spacer, so that provides stability to the joint. Number one. Number two, you should use a Palakos cement as a spacer because of its color. That when you take out the cements, it's easier to differentiate between a sclerosed bone and the cement, or else you add methylene blue so that there's some kind of color cement is there. And number three, Palakos cements elutes antibiotic in higher concentration compared to other cement that has been shown in the literature. So that is the best cement to use as a spacer. Now the question is, Rajiv, can you stop sharing your screen? And what are the disadvantages of static spacer? Can you just enumerate for benefit?
The disadvantage of the static spacer will be the fibrosis. This patient had an unstable joint pre-operative or at the time of the first revision, stage 1. But if there is no instability at stage 1, probably it's a better way to use a articulating spacer, because the second stage surgery, the revision second stage will become very easy. When you use a static spacer, the biggest problem is the stiffness and the exposure.
Yeah, exposure. Second stage exposure becomes difficult in static spacer because the parapetal gutters are all fibrosed. You have to dissect, to a greater extent. Sometimes, the patella gets stuck to the anterior part of the femur, and in the static spacer, it may get fused. So you have to be careful that there should be a layer of cement between anterior part of the femur and the patella. And then what is the disadvantage of a dynamic spacer? Dr. Vosley, would you like to take that before I come to Vijay?
Yeah, one very important point of static spacer, there's a quadriceps contracture. Now in this case also, he had to do osteotomy, and you can't depend on the soft tissue for stability. Maybe it is better to prefer a rotating hinge. That is one issue. Now, disadvantage of the articular spacer, one is if you use a cement hand molded, it should be very smooth. Otherwise, there are particular debris on movement. It accumulates and causes extra fibrous reaction, which is not very helpful. Second thing is sometimes there's a mechanical breakage on movement. If the cement is uneven, then it known that it can break and gives the extra instability to the joint. Third thing is if you use metal processes with the poly, it has been shown that it has got an adhesive property for germs to get again biofilm earlier. So these are three disadvantages. And
so though the soft tissue sleeve is maintained and exposure becomes easier in a dynamic spacer or the articulating spacer, but there is a possibility of more bone loss when the patient mobilizes the joint because of the cement. Yeah, Vijay.
Yeah, can I make a point? Yeah. So it was, thought that a articulating spacer will be better in terms of mobility and all that. But for example, endoclinic, they use only static spacers now. Yeah. So the reason we found out why static spacers give stiffness is because of two things. One, you don't make maintain the collateral length, and you don't do anything to the patellofemoral articulation. Rajiv showed excellent spacer, but it's very important that somebody distracts the joint when you are measuring for the spacer, and make sure that the spacer is the right thickness, that your collateral length is maintained. That's the key step. And then, of course, you put something in between the patella and the femoral surface. And when these two are found, you don't lose any range of movement at all. We just get that back in no time. And then now, the results of static spacers, many things are same as static as mobile spacers, but articulating spacers are more expensive. They have complications, and they need a lot of experience to do that. So if you're a junior, it's best to go with a static spacer.
Yeah, well, one more important point which Rajiv pointed out, that while the cement is setting, you have to hold the soft tissue together. Otherwise, there may be difficulty in closing your soft tissues. Sometimes, when the cement sets and you are not unaware, there will be expansion and it will be difficult to close the, soft tissues. That was one disadvantage, that was one point which one needs to remember there.
One care, Subhranshu, that when we use the static spacer, it should not be left in place for a very long time. In a period of 3 months, 4 months, you must go ahead with the second stage revision. Otherwise, the exposure is really difficult.
Yeah, this is just one monoblock spacer I'm showing. This is a patient in primary total knee was done in 1998, got infected in 2002, polyarticular rheumatoid, and from 2002, when there was a debridement was done, patient collapsed on the table. She was 72 years old lady. But afterwards there was a recurrence of infection, then nobody attempted a surgery. So 16 years old periprosthetic joint infection when he presented to me in 2017. This was a balloon knee, polyarticular rheumatoid, discharging sinus, only yearly twice she was aspirated. Whatever pus comes out, fortunately she didn't go into any septicemia or bacteremia. So when she presented with this dislocated osteoporotic knee, and she was advised amputation for that knee, what we did, we took out the implants and prepared a static spacer like this. Rajiv, you prepare with your gun, syringe. I prepare with a 5cc syringe. I take 2 5cc syringe, join them, then prepare the cement cigars like this, putting the K-words inside, then cut those syringes and these cement cigars are out. Put 1 cement cigar inside the femur, 1 cigar in the tibia, then these K-wires are projecting there. And as Vijay told, that maintaining the soft tissue tension, their collateral tension, you fill it with the cement and hold it in that static position till the cement sets. That is the post-operative X-ray of that patient. And as you can see here, AP and lateral view. So the wound, everything healed. Now at least she's walking with with a rollator there, and polyarticular rheumatoid, all the joints are deformed, feet are deformed. He has special kind of shoes there. This is just 2 to 3 years follow-up of this patient, and she's mobilized with this. And this is how we prepare articulating spacer. This is ankylosing spondylitis. This is, we have made same polyselection templates. This is on the femoral side, we prepare a template like this. And this is on the tibial side, we prepare the template like this. This of course is not available for commercial use. This is after putting the spacers inside. This is how the X-rays looks like. Then after this is of course second stage. I'll just quickly and show that is the 4.5 years follow-up this patient. Yeah. Any other questions, or we'll move ahead to the Krishna's case? Any questions from the YouTube? Krishna, would you like to share your screen? Yeah, Asit. Yeah, Asit, your question.
Okay, yeah. So just a comment. So what Vijay told is, the endoclinic, which is doing maximum infection work, is preferring most of their cases the static spacer. So do we think that role of mobile spacer is not so much now, because we know we can get on with the second stage quite early in 2-3 months time, and if we have followed the static spacer guidelines properly, we should be able to do a second stage without much difficulty. Is that right?
Absolutely.
It depends that what is your duration in between 2 stages, first stage and second stage. That is not clearly defined in the literature. That is a surgeon's preference.
Correct.
Some people even like in Salvi Hospital, they put the static spacer after 2 weeks, they go ahead with the second stage.
Really?
And endoclinic, sometimes they go with the single stage revision.
Mm.
So if the duration of your second stage is much longer, or the patient is unreliable or will come very late, then static spacer will lead to a lot of fibrosis of the tissues. Then exposure becomes difficult, and subsequent range of movement after second stage may be restricted. So articulating spacer provides that thing, that your range of movement will be much better. You understand that?
one very important point I would like to share. Endoclinic experience is exclusive. I think what they do, their way is radical debridement. They remove all collateral, and every case they use a rotating hinge. And their rotating hinge is a hinge loaded. It has no contact with the femur articular and tibia articular. And their way is radical, and they are successful. They feel that collateral ligament, when you remove the exposure, everything becomes easy, and debridement is perfect.
Yeah, good points. Let's go ahead with Krishna's case. Yes, please.
Yeah, thank you, sir. My case will highlight the role of intra-articular antibiotic delivery. Just a second. I'm sorry about that. So my case will highlight the role of intra-articular antibiotic delivery for infected knee arthroplasty. So direct infusion of intra-articular antibiotics has been used to salvage acute and chronic infected total knee arthroplasty, and there are several references to this. For example, the vancomycin tissue distribution is 30% of the serum level. So if we have 100% of serum level achieved, then inside the joint, the concentration is around 30%. And for achieving an MIC of 4 microgram per ml inside the joint, serum concentration of almost 15 microgram per ml must be achieved. And therefore, comparing intravenous with intra-articular injection, it suggested that minimal synovial fluid levels achieved from intravenous dosing would become subtherapeutic after 6 hours. And we know from our experience of these bacterial organisms that you need to have a sustained supratherapeutic elevated levels inside the synovial fluid in order to get good infection control. And a lot of the IV doses are not able to achieve this sustained control. And this contributes to the development of small colony forming units, and resistant biofilm formation and resistance of antibiotics happens because there is a waxing and waning of the intrasynovial levels of the antibiotic following intravenous administration of the antibiotics. So this case is a 54-year-old lady who presented to us with pain and multiple discharging sinuses over the right knee. Her ESR was 120 and CRP was 80 at presentation. She had no comorbidities. The patient had an infected right knee replacement. The index procedure was 18 months back. A debridement with implant retention was done 15 months back. And the persistent infection led to a 2-stage revision, which was done around nine months back. And Pseudomonas was grown in the culture at the time of the 2nd stage revision. And this is her X-ray right now with multiple discharging sinuses. And you can see that the femoral component is loose and migrated laterally, and you can see some bone formation there. So if you look at the options for her, because she is young, less comorbidities, the options could be repeat 2-stage revision or arthrodesis. And if you look at the literature, actually, arthrodesis is strongly considered after failed 2-stage reimplantation in TKA. And the 2-stage exchange has got a failure rate ranging from 11 to 24% reinfection. And Dr. J. Parvizi talked about this 25% failure at 2 years. And we must look at this in perspective, because a lot of the reinfections happen between 6 months and 18 months after the thing. And in some papers, the reinfection rate is as high as 40%. So that must be kept in mind. So is there a role of local antibiotic delivery? This paper from Leo Whiteside, who described the technique, had good results with MRSA, managed with 1-staged cementless revision with intra-articular vancomycin through Hickman catheter. So he used 2 Hickman catheters inside the joint and gave injection for 6 weeks. No IV antibiotics were given beyond 24 hours. So there are several conceptual advantages to local delivery of antibiotics. There is prevention of antibiotic resistance because you are maintaining a supratherapeutic levels of antibiotic inside the joint. And we are not looking at a minimum inhibitory concentration anymore, not MIC. We are looking at a biofilm inhibitory concentration, which is now a reality with local antibiotic delivery. You can make sure that there is antibiotic level inside the joint round the clock, and you can prevent systemic side effects because now you don't need to give as much duration of antibiotics. And a point here is that all of us have got almost 100 trillion bacteria inside us, which is called as a microbiome. And the microbiome role in the longevity of human beings is increasingly being studied. And if you just give an antibiotic for 3 or 4 doses, more than 50 to 60 bacterial species will get irreversibly damaged. In an infected situation, when we're giving 6 weeks of antibiotics, no wonder the mortality for these patients is higher, because they're damaging a lot of the normal gut flora, and the local antibiotic delivery definitely must be looked at in the future. The other option again has been published by Leo Whiteside on the technique as to how this particular technique is used, and they did a synovial fluid measurement, also serum measurement following intra-articular delivery, and they had 95% success rate in managing 2 difficult categories of patients, the MRSA and failed 2-stage revision with intra-articular infusion of antibiotics. At our institute, it's a normal practice to use intra-articular antibiotics and minimize the use of intravenous antibiotics in our patients, and we've been doing it for the past 10 years. So this patient underwent a stage 1 revision with an antibiotic spacer, and local antibiotic delivery of colistin was given in this case with 3 million units once daily for 2 weeks. And we know that colistin is a very toxic antibiotic, can cause nephrotoxicity. So if you have multi-drug resistant Pseudomonas or gram-negative bacteria, good option to give colistin 3 million units once daily for 2 weeks through the pigtail catheter. And the culture grew Pseudomonas and Klebsiella. We are finding more often nowadays gram-negative infection, polymicrobial infections in our patients. We gave IV antibiotics for 2 weeks. It's important to give for 5 to 7 days at least, because you want to have some level of MIC to be achieved in the serum before the local delivery takes over. And all patients are given probiotics, which is an often overlooked feature in these patients. You must give them Bifidobacter and Lactobacillus species in order to minimize the level of microbiome damage which happens in these patients. And that's the pigtail catheter which we routinely use. And we were not happy with the initial spacer because there was no intramedullary extension. It was an error which I made. And so I repeated the spacer exchange after 6 weeks because it was a multiply operated and failed revision scenario. And now after the 6 weeks after the second spacer, the knee aspirate was negative. The ESR and Cedrate's CRP settled. The wounds were well healed. And we planned a revision totally arthroplasty with metaphyseal sleeves to manage the bone loss. And we used a hybrid fixation. We used cemented on the surface and uncemented inside the medullary canal. The advantages are there for both cemented and uncemented fixation. The cemented has option of local antibiotics, and uncemented may be easier to remove in cases of reinfection, which happens early. And that's the 1 year follow-up of the patient. You can see the multiple healed sinuses on the leg, one on the medial side, one on the inferolateral side, one on the superior side. But she had a reasonable functional outcome. So to conclude, intra-articular infusion of colistin is an option in salvage of failed 2-stage gram-negative infection. It is also our choice in patients with MRSA, where we are doing a 2-stage revision. So you give intra-articular 500 milligrams of vancomycin, and it's an option which is often overlooked but must be considered in my view. Thank you.
Thanks, Krishna. Great
Yeah,
case.
very good, Krishna.
Good case. Can you just elaborate a little bit on the procedure?
On the catheter,
yeah,
also very important.
Yeah. What catheter you take and how much antibiotic, how the entire procedure, just a little bit for the
very interesting
for all of us.
So the original technique by Leo Whiteside looked at Swan-Ganz catheter, which is used for CVP lines. The Swan-Ganz catheter is reasonably expensive, and the original technique describes 2 catheters which are inserted into the joint, and he combines it with a 1-stage cementless revisions. The reason being, his antibiotic profile is for 6 weeks. He doesn't give it for 2 weeks as we do. He gives it for 6 weeks, and there is a sinus formation around that catheter because it's made of silicone, and that requires excision. So what we found is that if you use a pigtail catheter, which is a urologic catheter, which is used for draining a pleural effusion or an empyema, and it has been used to inject antibiotics into the pleural space. So you use a 10-gauge pigtail catheter. It's very cheap and it's available, and you insert it in the joint and use it for 2 weeks, at most 3 weeks. Then the risk of sinus formation is almost not there, and you can just pull it out. And we've had a reasonably good outcome in almost 67 to 70 patients where we have done 1-stage revision and 2-stage revision, and it is our protocol of choice currently. So we don't do any infected case, whether it's trauma or arthroplasty arthroplasty without using a pigtail catheter. So we insert it, use stitches to anchor it, and then train the patient to give the injection in a particular way in the ward when the patient is admitted. And at the time of suture removal, it is removed. And we've not had problems with sinus formation or issues with the catheter itself. We don't give IV antibiotics.
Another catheter and just suck it out after a couple of contact time of certain period, like that. Only one catheter.
The dose of antibiotic is much lesser as compared to what you give for a normal, if you want to give an IV antibiotic and you want to achieve MIC, the level of antibiotic which you have to give is much higher. For an intra-articular use, the concentration inside the joint is 750 times. So that has been studied as compared to what it happens in the serum level. So there is no question of that antibiotic dipping down below the level of MIC which is required. So that's why I talked about the concept of biofilm inhibiting concentration. So it's a BIC. It's not MIC anymore, it's BIC. So your intra-articular concentration is maintained throughout the day. Single dose is enough. And we don't have the facility, but Leo Whiteside has actually tested the serum concentration and he has come up with that particular figure. He said 500 milligram of vancomycin is good enough per day. Single dose of 500 milligram is good enough to prevent toxic serum levels while maintaining good therapeutic concentrations inside the joint itself. So it has worked well in our hands. I'm not sure why it's not included in any of the thing, because apart from Leo Whiteside, nobody talks about this.
Yeah, very interesting, I think.
Asit followed by Vijay.
Yeah, now Leo Whiteside was here in 2017 in Calcutta, IAA, and one of the subsequent, previous meeting also. I spoke to him. Why? No, he is a very good teacher and he's done this. No one, even in US, Northern America, follows this particular way of treating the local antibiotic delivery system. It appears very, very appealing, and as Krishna has shown us that it really is effective and reduces IV dose. My question to Krishna is, if your antibiotic sensitivity and the microorganism that you get from the first stage of revision, would it change your antibiotic? Because you mentioned about colistin, he mentioned about vancomycin. So what would be your antibiotic choice?
So colistin is now, colistin will definitely do an intra-articular thing because it's a toxic antibiotic. But if it's a gram-positive organism, we've been using vancomycin. So we will use vancomycin. There is literature evidence for gentamicin and amikacin intra-articular, and they've measured the concentrations and the therapeutic concentrations are there. Colistin, there is no evidence as such, but there is evidence of use of colistin inside the polymethyl methacrylate spacer. So the paper which has looked at the role of primary antibiotic-laden cement in primary joint replacement looked at gentamicin and colistin impregnated bone cement versus no antibiotic bone cement. So colistin theoretically is heat stable, can be used inside the joint, can have some sort of percolation. So we've been using colistin only in the gram-negative multi-drug resistant organisms. So we're using that because we had problems with the IV use of the particular drug. But other patients where there is gram-positive or culture negative. So 35%, I must admit, in our center are culture negative. 65% we're able to get the organism. And only 40% we are able to identify before the intervention. So even if I do a one-stage revision, I'm able to identify organism only 40% of the times. Intraoperative culture will give me another 25% success rate. But 35% of them still we can't grow any bug despite all the effort. Correct. We put in a blood culture medium, we put it in the thing. That is a fact for my own practice. And whenever I don't grow any bug, I still give vancomycin for 3 weeks. That is my own practice protocol.
Yeah, Vijay.
Yeah, we have experience with it. The reason why it's not popular is, most of those guys deal with gram-positive infections. And when you have a cement spacer inside with vanco, there's no need for any intra-articular catheter. It does its purpose, So the catheter is meant for cases where you don't get proper antibiotic delivery with cement spacer. Now, the colistin is the classical example where we use gram-negative, not for the initial period of that we use in the cement. So if I cover the initial phase, but prolonged, there's no oral antibiotic, and you give them a shot of colistin, their kidney packs up. And that's when this really comes into its play. And then you're able to think. But the real practical difficulty is that if you extend it, so assume that the antibiotic delivery from the cement is for 2 weeks or less. Where you want this to act is beyond that time. but you cannot maintain the catheter beyond that time, you know. So you're parallel with the cement. And that's why we are not very enthusiastic. We are very enthusiastic at one point in time, but we cannot maintain it for 6 weeks, for example. It doesn't work that way. Yeah. So it's a, you know, practical problem that we have. But the cement does the same job. If we're able to get a good sensitivity, put the antibiotic in the cement, it does the same job. That's why it has not got popular. The reason why Inno uses it is because it does one stage non-cemented PKR revisions. He has no other choice. And we don't do that. And that's where he alone used it and nobody else used it. That's why Thorsten, Jay, everybody are against this concept.
How many of you use this local antibiotic delivery through stimulant or calcium sulfate cement granules?
Yeah, it's, I think, very useful.
We now use it routinely, but that I think is a very recent concept. Maybe last 2 years we are all using it. But Leo Whiteside described this 15 years ago. So I don't know. So a little, you know, things move on. So now there are that one also.
There are different methods of local antibiotic delivery. This is, you know, catheter, through stimulant, or through collagen fleece, some sponges. There are so many things have been described in the literature. But as Vijay told, you know, maximum antibiotic delivery is 2 to 4 weeks, either from the cement or from, you know, catheter or whatever. That is the maximum, you know, time of antibiotic delivery. Well, what, you know, what we have not discussed properly, what are the antibiotics can be added to the cement and how much antibiotic should be added to the cement, one by one? We start with Krishna.
Yeah, you can use any heat stable antibiotics. It has to be heat stable and 10% weight by volume. So if it's doesn't exceed 10%, that should be all right. Otherwise, the cement will denature. But if you're using it in an articulating, in a static spacer, you can increase the dose maybe to 20% because it's not going to be a sort of a long-term solution for you anyway. But if you're doing a one-stage revision or using an autoclaved implant or a new implant in a one-stage manner, 10% probably is upper limit.
Yeah, you know, the international consensus group recommend 5% volume by volume of the cement for the final fixation of the prosthesis. If you're using as a spacer, yeah, you can use more because that makes cement more porous and that elutes antibiotic in a higher concentration when you're using a cement spacer. The Vijay, what are the antibiotics? Name some antibiotics that should never be added to the cement, should not be added to the cement.
I'm not sure about that, Differential. Yeah, so Banco, Tobra, Genta, Colistin we add. I don't know about what should not be used. I'm not sure.
Yeah, you know, this macrolide antibiotics that should not be added. Penicillin should not be added. Rifampicin should not be added because rifampicin in the cement doesn't harden for days together. So these are the antibiotics should never be added to the cement. As Vijay told, vancomycin, cephalosporins can be added. You know, you can add ticoplanin, all these things, antibiotics can be added.
Quinolones can be added. I don't think quinolones can be added.
No, quinolones, so we don't add. Quinolones cannot be added. These, you know, best antibiotics are aminoglycosides. But problem is that in our country, aminoglycosides are available in liquid form. They do not recommend adding liquid antibiotics to the cement. It should be in powder form. But abroad, you know, tobramycin and all, it's available in the liquid form. That's why we use the pre-mixed antibiotics which are available in the market, like gentamicin or tobramycin impregnated cement. Yeah, Rajiv, anything you would like to add?
I use the vancomycin and tobramycin in all cases, and you are right that tobramycin, all these antibiotics are available in the liquid form. So but the ideal amount of tobramycin is about 3.6 grams in a pack of cement, which is not possible when we are using a liquid form.
Yeah,
so I think that's a little disadvantage for us.
Yeah,
but if you use the vancomycin, you use about 3 grams of vancomycin per pack of cement.
Yeah, that is.
But you get pre-mixed Tobra, yeah, that's what we use.
Yeah, what we used, all the aminoglycosides are pre-mixed because you can't add these liquid antibiotics that grossly alters the, you know, cement properties. What are the antibiotics you add to stimulant?
To?
Sir, like a hello.
Yes.
Stimulant, they give the composite to mix up with vancomycin. But we, instead of that, we use gentamicin to mix the stimulants along with the vancomycin, so that with the limited supply, you get the dual antibiotic course in stimulants. And coming to the cement, we had a couple of cases where the TB was proven, and if we are planning for rifampicin, we are like made sure that we will spend extra 20 minutes for the cement to set. The color will be changed orange color, and it will take another 15 minutes to settle. But ID people feel it is like it's a suggestion, because the endoclinic, they have a IV rifampicin, so they are like much more aggressive. We don't have the IV here, so we preferred using rifampicin in cement along with it.
In tuberculosis, we had streptomycin. Streptomycin and the aminoglycoside, the powder is very much available. So in tuberculosis, we had streptomycin. Rifampicin injectable form is not available in our country. You know, it's not recommended by FDA India. But you know, rifampicin tablet though available, that's not available. For stimulant, when you add, we have added, you know, gentamicin and liquid antibiotics to stimulant. But please remember, when you add gentamicin, then you should not add the liquid which is provided by the stimulant. You add just the gentamicin, because if you add the liquid, you know, along with gentamicin liquid, then the stimulant doesn't set. It takes very, very long time. Then you are held up on the table. So in stimulant, it is not a very, you know, exothermic reaction. So you can add other antibiotics. They have got certain recommendations. But one thing to remember, that when you're adding gentamicin like liquid antibiotics, please do not add the liquid which is provided by the company. Yeah, I think we have discussed everything we have covered. Any other questions, Abhinav, or else we can wind up?
Sure, Shubhranshu, before we close, in a case of the periprosthetic joint infection, we must talk about at least mention the name of arthrodesis and the implants for arthrodesis, the newer implant for arthrodesis.
Yeah.
So that is also one of the in cases where you have an intractable infection, failed revisions for infection, the arthrodesis remains the last choice.
Yeah, I agree.
And you have certain implants available these days, which you have which will work as a arthrodesis device.
Yeah, thank you. Now, before we wind up, I'll just go ahead with the for our next webinar. We now give little bit of rest because we are going out of the lockdown. So we'll have our next webinar on 20th of June 2020. That is a Saturday. And we'll have a webinar on total knee arthroplasty for knee arthritis with extra articular deformity. And Dr. Rajiv Sharma is going to moderate that session. And our guest faculty will be again Professor Jean-Louis Brad from France. I thank you all for attending. I thank all the faculty for being here, and have a stay safe, stay home. And now we brace for our openings for the, you know, for our work now. Now I stop sharing the screen and I close the session. Thank you
very much. Thank you very much.
Should I stop the live stream?
Yeah, please.